All right. Thank you, everyone, for joining us today for our meeting on harnessing the power of patients and stakeholders to advance the research goals. This meeting will be held from 1 p.m. Eastern Time to 5 p.m. today. During the meeting today, you will be able to take advantage of the Q&A feature to submit questions that we will try our best to answer during the Q&A period. To do so, you can simply select the Q&A button at the bottom of your screen. You will see a box pop up and you will be able to type your question and submit it. There is also closed captioning available in this meeting. To view it, please, you should notice that in the bottom of your screen near the right, there's a closed captioning button. Simply select the little arrow next to that and select show subtitle. And now I will pass it off to Danielle.
Hey, good afternoon, everyone. Thank you so much for joining our meeting, Harnessing the Power of Patients and Stakeholders to Advance the Research Goals of the NIH HEAL Initiative. This is our second HEAL patient engagement meeting. And today's meeting, we're really going to focus on showcasing some of the patients and stakeholders who are involved in many of the community advisory boards, participate in advising a lot of our HEAL investigators on the engagement within their trials. And then we'll move to the investigators who have really taken to engagement within their overall studies. Our first speaker today will be Dr. Rebecca Baker, Director of the NIH HEAL Initiative. In her role, she leads coordination of the HEAL programmatic activities with NIH institutes and centers. She manages the HEAL Initiative governance committees. Dr. Baker helped design the initiative. She helped design the HEAL Initiative, working closely with NIH and IC leadership, and advises and represents the NIH Director on HEAL-related activities, including interagency efforts. She previously served as Special Assistant to the NIH Director and as Policy Analyst in the immediate office of the Director at the NIH, where she engaged in efforts related to the Precision Medicine Initiative and the Cancer Moonshot, and the NIH Office of Science Policy, helping to develop the genomic data sharing and scientific collection policies. We welcome Dr. Baker.
Thank you, Dr. Haney, and thank you to the rest of the Patient Engagement Working Group of the NIH HEAL Initiative, or helping to end addiction long-term. It's a pleasure to see this meeting come together and see the progress that this group has made, and I look forward to a really interesting discussion today. So next slide, please. So here is the crisis that we're up against: a rapidly evolving public health emergency of opioid misuse, addiction, and overdose. Sadly, we saw over 70,000 Americans died of a drug overdose in 2019. The majority of those deaths associated with opioids, and these are loved ones, colleagues, family members, children, neighbors. These are people in all of our communities. And so we at the NIH are working with all of the stakeholders we have, including those of you on the phone today, to come up with scientific solutions to this crisis. And know that it's not going away. We're seeing, sadly, in the COVID era, signs of increase of drug use, signs of increase in overdoses, and really requiring that we all put our collective heads together and come up with durable solutions to this crisis. And what we recognized early on, next slide please, is that this is going to go beyond just understanding drug overdose deaths, but also understanding the needs of the millions of Americans who experience pain. So 50 million American adults are affected by chronic pain. About half of them experience pain every day. And a little bit less than half, about 20 million, have such high impact chronic pain that they can't go about things that are important to them. So that could be family responsibilities, work responsibilities, other things that give them joy and fulfillment because of their pain. And so recognizing the urgency and the magnitude of these two crises, the NIH pulled together the HEAL Initiative. Next slide, please. Helping to end addiction long-term. This is an ongoing and sustained research investment of over $500 million every year towards research to understand pain and addiction. It comprises over 25 different individual research programs, and these span really the range of biomedical research at NIH, from prevention science, understanding people at risk of developing chronic pain or opioid use disorder, basic and translational research, seeking to develop novel targets and therapeutic treatments for both specific pain conditions and also opioid use disorder. A large number of clinical trials, understanding the best treatments for both pain and addiction, and for specific conditions and in specific settings. And then lastly, a pretty significant investment in implementation science. For a lot of people with pain and addiction, we have effective interventions that aren't making their way to patients. And so research trying to understand how best to implement these evidence-based interventions in the real world. So as you might imagine, from such a breadth of research topics, we have many different NIH institutes and centers involved, 12 leading individual programs. We have a governance structure that takes into account experts all the way from back pain to therapeutic development to mindfulness and lots of different elements of the HEAL Initiative. And then we work in partnership. We work in partnership with you and folks on the meeting today, with communities on the ground, with our partners in the private sector, as well as other federal agencies, recognizing that research alone is not going to bring about solutions, but we can do it in partnership with all of you. So next slide, please. Here is how we organize our research. Generally, on the top half of the circle, you'll see research enhancing pain management. That can be preclinical research, working on therapeutic development, the development of new treatments, and accelerating through the pipeline, the testing of new treatments for pain. And then in the clinical domain, understanding for people with specific pain conditions, what interventions work best. Then on the bottom half of the circle, you see improving treatments for opioid misuse and addiction. This includes coming up with novel medication options, understanding the needs of infants born exposed to opioids who might go through withdrawal in the NICU, understanding new prevention and treatment strategies. This is how mental health, how the transition from adolescence to adulthood, all of these factors, sleep, come into play, contributing to the risk for opioid misuse and addiction. And then lastly, translating research into practice, working with partners and working with all of you to put into place the interventions that we know work. So I'll now tell you a little bit about a few of these and how we think of research as being part of the solution. Next slide, please. Here's one problem. There are 3 FDA-approved treatments for opioid use disorder: methadone, buprenorphine, long-term naltrexone, and there are very effective ways of reversing overdose, such as naloxone or nasal Narcan, but many people with opioid use disorder never receive appropriate treatment for their condition. So how are we at the NIH working to address this as a research question? We are testing integration into community justice, emergency settings, other places where people with substance use disorders come for help. And we're testing how effective it is to integrate into those settings specific approaches from a menu of evidence-based interventions that are targeted for those communities. And you can see here this image focused in one community in Kentucky on how to train people to carry and use naloxone for the reversal of overdose. This is just one example of many, many research studies we have in this area focusing on communities and partners across the country. Next slide, please. Another problem is that even when people do receive these medications for opioid use disorder, many of them don't stay on treatment long enough to sustain or accomplish long-term recovery. And so we're trying to treat this like a research question. What else can we give people with substance use disorders, people with opioid use disorder, or people in recovery to sustain their recovery. And it might be innovative approaches such as immunotherapies to prevent relapse and overdose. It might be small tweaks to medications that we already have and we've already clinically tested, so making them more extended release, so a person doesn't have to go to the doctor's office as often. And then it might be addressing other aspects of addiction beyond the ones that we have medications for now, such as craving or perhaps even sleep. So this represents a combination of many different research programs within the HEAL Initiative, all seeking to provide these more user-friendly medications for the treatment of opioid use disorder. Next slide, please. Across all of the different areas of research focus that I showed you before, there have been certain themes that have popped up. So one of the themes is the need to share the products of our research. This includes data, findings, other elements of a research study. We are facing a national crisis and we can't delay the sharing of the products of our research, putting them into journals, letting them sit for months and years. We need to get those out into the community so that they can be read, used, translated, put into practice. So HEAL has created a data sharing policy, a secure infrastructure for sharing data while protecting the privacy and confidentiality of research participants. And I'm sure you'll hear more about that over time. We also have recognized that across the pain and addiction landscape covered by HEAL, we have a real duty to engage with the populations that we're serving. That includes our research participants, patients, family members, other stakeholders, making sure that the way we're doing our research is going to produce meaningful change for them, that we're not just studying around the problem, but that we're providing solutions that are going to be meaningful to those patients. And then lastly, the importance of partnerships and diversity and the importance of inclusion within HEAL. We're not going to be able to provide scientific solutions to the opioid crisis if we don't consider the full breadth of a person and then the full dimension of a community that's affected by this crisis. And so this is an important theme within HEAL that I'll tell you more about. But now, next slide, please. A note from my boss, Dr. Collins, the NIH director, about the importance of engagement and the importance that everyone has a chance to participate in clinical trials. We really, through the COVID vaccine research that's taken place over the past year, really become aware of the importance of and also knowledgeable about tools to help make sure that our research studies incorporate the right inclusion and diverse populations so that they can accomplish our really important research goals. Next slide, please. This isn't the first meeting that we've held on this topic. My colleague Danielle Haney alluded to a meeting that was held in August of 2020 and included some of the folks that are going to be on today's meeting who are on the HEAL Patient Engagement Working Group, but also Dr. Korschatz, Director of the National Institute of Neurological Disorders and Stroke, as well as other researchers, participants in research and other community leaders to help us get a sense of what are the opportunities and challenges that we face incorporating patient perspectives into research. And so today's discussion will follow on with some more concrete examples and data that we've gathered. So next slide, please. We've broken the goals of the patient engagement efforts within the HEAL Initiative into 3 spheres here. First is to create a governance structure to make sure that we are holding ourselves accountable, measuring, assessing, and being really keeping the fidelity of our process, making sure that we continue to engage patients in research. We also seek to provide resources for the HEAL research community and beyond. And then lastly, work to increase patient engagement within specific HEAL studies. So next slide, please. Here's how we're doing on each of those areas of priority. We have created a patient engagement work group. That's the work group that has pulled together today's meeting. And we are have efforts underway to build a HEAL Community Council, which I'll tell you more about, as well as plans to monitor engagement and recruitment across the HEAL Initiative. When it comes to increasing patient engagement in HEAL studies, we have very hot off the presses a new notice of special interest allowing existing HEAL studies to request additional funds to enhance diversity, inclusion, and patient engagement activities within their studies. And then lastly, providing resources. That's where we work to come up with best practices and principles, do some focus groups and other ways to make sure that our patient engagement efforts are meaningful and being used by our different research programs within HEAL. So next slide, please. Here is the terrific working group you heard from Danielle to start. They have been early and often reminding us in HEAL leadership and across NIH about the importance of patient engagement within HEAL, and they're the ones who are coming up with the innovative and forward-looking strategies to make sure that we accomplish our goals when it comes to including patients in research. Next slide, please. Here is a vision for the HEAL Community Council. This will be kind of a complementary group, not NIH staff, but instead people with lived experience to help us by providing input on issues that are facing people who are participating in our research studies. And this could include giving us recommendations on how to overcome barriers to recruitment, how to design studies that are meaningful in the outcomes and approaches they take to understand pain and addiction, to identify best strategies for communication and connecting investigators and stakeholders, and to inform our overall leadership and governance structures. Next slide, please. So I'm really excited, having said all of that, I'm really excited for today's discussion, hearing from all of you, hearing from our leaders and our scientists, and most importantly, patients and stakeholders on what they would like to see in HEAL, and showcasing the work that's underway with our vision on the future and what can be accomplished. So next slide, please. And to give you a sense of what we're up to, we're now working with scientists to understand what they've already done, gathering input, that's you, from community stakeholders, and developing a plan to promote representation among participants in HEAL studies. Next slide, please. So, and I alluded to this, more information is available on the HEAL website, but if you are a researcher funded through the HEAL Initiative and you would like to increase your efforts either in engagement of research participants or in diversity and inclusion, there are opportunities out there for research supplements to do so. Please check out our website. It is not a long window to apply, so get those applications ready. This is a really important goal for HEAL and a really important activity to strengthen and ensure that we're carrying out appropriately. And then last slide is, as I said, HEAL is ongoing. We have research opportunities that are on the street now across all of our disciplines and areas of research focus. So if you'd like to be part of the initiative and you're not already, please look at the funding opportunities online. And with that, I look forward to a really terrific and robust discussion and welcome my colleague, Dr. Nora Volkov, Director of the National Institute on Drug Abuse, to share her thoughts and wisdom with us today. Thank you.
Rebecca, hello. Thanks very much. And good afternoon to everyone. It's a pleasure to be here. And I hope next time we're doing it in person and we can actually interact with one another. But in the meantime, there's a lot that we can do. And as Dr. Baker mentioned, there's a lot that has been going on already during these very difficult times of the COVID pandemic. And while this has been quite devastating overall in terms of the consequences to the nation, for people dying from the economic downturns, and two, for the pandemic, it actually has significantly increased the mortality at an estimated rate of at least 24% higher number of people dying in 2020. But we have also been able to learn to do things better. And it also, I think, has made us conscious of factors that we have neglected in the past, and that by being aware of them and coming up with strategies to remediate that, they would make us better able to advance our science. And I view that this meeting that we are right now on to try to figure out how we can increase the interactions between formally scientists, but extremely important, the patients themselves that are suffering from addiction and their families, to obviously optimize the way that our research is selecting the questions that are most important. But I also think it is crucial and something that we need to explore even more, to bring them into the science enterprise directly so that they can be part of the citizen science. And so when I think about the notion of diversity, I mean, which again, COVID pandemic has made us aware how extremely important it is to have diversity in our science place, to have diversity among the patients. But I also think it in terms of the diversity of the thinking that goes from someone that has lived a disorder, as opposed to theoretical scientists that thinking about these problems. Of course, if they don't first of all touch out to create that dialogue with the patients, they're going to be left in the theoretical world. So that's number one. But what about going more than that and bringing the patient's perspective as part of the databases that we are creating so that we can explore them and extract information that is incredibly valuable? So as we are right now, and I like to see it as when we get rid of COVID, which we will, what are going to be the after times after that COVID control? And how is that going to be relevant for the opioid crisis? Well, the after times are going to see a devastation in the opioid crisis and some challenges imposed by the stressors linked with a downturn of the economy, which we know are relevant for increasing relapse and drug taking. So we need to be aware of that. So we need to position ourselves in a way that we will be prepared and use what we've learned during the COVID pandemic to do things better in the opioid crisis. And that requires that we work very, very closely with patients, families, and organizations that are bringing them together. And so that's why I'm so excited about this meeting, because it's like building the architecture for making this happen. How I think it is so obvious how important it is to have the patient voices in what we do. And I always confess this, it took, I mean, I realized that later than, it's better to realize it later than never, but it took me several years to realize how important it was. And I think it became most clear in my mind when we joined forces with the Addiction Policy Forum, which is the largest organization of patients and families with a substance use disorder, to bring forward the voice of the patients into what is important for them as they look forward for better treatments for their disease conditions. And it was in that meeting that we did jointly with them and the Food and Drug Administration that I actually had that aha moment that said, oh my God, this is as important as anything else that we've done in science. And why was that? And as we were discussing, us from the scientific world and listening, really listening to the patients about why is it for them so difficult to actually stop taking drugs? Yes, the craving was important, and that's what all of our work has been going on after. But as important, they described the challenges from feeling depressed, the challenges from not being able to sleep. And that aha moment came when we said, well, how about we start to think about treatments that improve these symptoms in order to help the patients, because these are meaningful to them. So this is just an example of one of them. But as was mentioned by Dr. Baker before, it's not just only the patients, it's the families. And addiction is a social disorder in that on the one hand, it's social circumstances that trigger, that increase your vulnerability, but it's also social structures that support you. And without them, it's much harder to achieve recovery. And thereupon, the importance of listening from the experiences of the family and the family members. And to bring that experience in, and I'd like us to be able to explore that in ways that we can transfer it into a format that can be used for data analysis to create that ability of bringing together the information that otherwise is experienced by the person suffering from the disorder, but many times is not heard by those doing the science. I also think it is a crucial interaction, because addiction, whether we like it or not, continues to be terribly stigmatized. And that stigma is basically defeating all of the purposes and making our challenge so much harder. People that are suffering from a disease of addiction will not seek help for their treatment, will not seek it because they don't want to be discriminated in a healthcare system that basically dismisses them. And so therefore, in terms of what is the communication, how we educate, how do we address bias, conscious and unconscious biases that feed that stigma for the individual, the family, the treatments, the treatment programs that deliver the care for those patients. What is the best way to jointly do it? And then again, the unique importance, and as Dr. Baker was commenting on her presentation, this has been one of the areas that we have worked very closely in the healing community studies to develop a campaign, an educational campaign, to communicate in ways that are meaningful to those that we want to engage. And so as we start today, this meeting, I am very excited to be part of it. I look forward for your comments, recommendations. I think this is an extraordinary opportunity that we do have to listen to one another, to learn from one another, and to communicate, because it is that ability of bringing together that diversity of experiences so that we can track into actions that will ultimately lead us to be able to much better treat substance use disorders, much better prevent them, and in the process, improve the well-being and health of our country. Thanks very much for this opportunity, and I look forward to the rest of the meeting. Thanks a lot.
All right. Thank you very much, Dr. Valcal. So now we will actually transition to our excellent, esteemed patient and stakeholder panel, where these individuals will really talk through the experiences that they've had in engaging in research and the research process. That discussion will be led by Ms. Jessica Hulsey-Nickel. She is the founder of the Addiction Policy Forum, which was founded to help families and patients struggling with disease and with addiction. I'm going to just quickly ask if we have Ms. Karen Lizzie in the audience. If so, please shoot us a chat. Please shoot me a chat so we can elevate you to a speaker. With no further ado, thank you all for joining us, and we really look forward to being educated by this panel and learning a great deal more, because once again, these are really the experts in the area of pain and opioid use disorder. Thank you.
Thank you, Danielle. First, my name is Jessica Hulsey with the Addiction Policy Forum. And I wanted to just start off by thanking Nora and thanking Dr. Volkoff and Dr. Baker for focusing on bringing patients and key stakeholders to the table. For those of us that work in the patient and family space, we're so grateful to you for your leadership and really prioritizing bringing patients and families into the fold, understanding what's happening with research, providing input. It's just so important to sort of see that work. And at Addiction Policy Forum, we represent patients and families in the addiction space. We work to translate the science for our members and try to strive to improve how patients are engaged in a research agenda and providing input. As Nora mentioned, we've worked with NIDA and the FDA on bringing patients to the table for drug development for both opioid use disorder and stimulant use disorder, and have worked with NIDA on a few real-time quick research projects to make sure we have the input from our patients and families in real time. I'm so honored to be able to moderate the panel today and have some amazing speakers and folks in this field who are doing great work in different aspects of HEAL trials to advance patient and stakeholder engagement through the whole continuum of research. So we're going to start off in terms of the format of our panel with every panelist giving a quick 5-minute overview of the work that they're doing. And then we're going to go into Q&A and have a discussion for the rest of our panel time slot. So with that, I'd like to introduce Anna Bartholomew to give us an overview of her work that she's doing, and then we'll keep going down the list of our amazing panelists.
Hi, thank you, Jessica. Hi, everybody. My name is Anna Bartholomew. I am here representing the PACT study. PACT study is, really quick, I should introduce a couple others. I have one of my colleagues, one of my nurses here, Deborah Mass. She's also maybe going to chime in a little bit. We've also got the PI of the PACT study from OSU on the call, Dr. Kara Rude, and then I believe Cora from the our data coordinating center is on the call as well. So we're all here. So a little overview about our study. I'm a little bit different than a lot of the other panelists in that our study is already started and we weren't able to like actively engage moms in preparation for the study. We had to use prior information. So the PACT study is called, it's a prescription after cesarean trial. It is part of the HEAL Initiative, and it is being done at the centers and sites under the Maternal Fetal Medicine Units Network. So the idea of this study is, when we were presented with this opportunity, we were very excited because we know that opioids and pain control are just so important. They're a vital part of the recovery for moms after they've had a cesarean delivery. We also know that there's differing practices among practitioners and also in different states regarding the number of opioid tablets. So there's not a lot of continuity. And then, when thinking about this and thinking about opioid tablets and leftover tablets, you get into thinking, okay, well, is there a way to get the mom involved and these patients involved in their care? Which brought us to the thought process of shared decision-making. And shared decision-making is when it's basically a conversation between the medical care providers and the patients. And it allows for patients to be a part of their care plan. It gives them autonomy and it empowers them, which is really, really important. So when we're designing this, or what we did when designing this, we looked at a bunch of different studies and we took all these different ideas and we looked at some smaller studies that showed that when looking at moms who have had a cesarean section at the time of discharge, if there was some shared decision-making in terms of how many opioids the moms went home with at the time of delivery, they often went home with less tablets. And then they also had less tablets left over that could, wind up potentially in the wrong hands. So we decided to design this study. And it was, it's very exciting. We decided to look at this one size fits all versus a more of an individualized approach. So when we say an individualized approach, we talk about the shared decision-making. So having that conversation with the patients, but also giving some education on what to expect in terms of pain, because a lot of moms, especially if they have not had a cesarean delivery in the past, they don't know what to expect because it's very different than a traditional vaginal delivery. We also review their opioid usage. So we look at the last 24 hours and we say, this is what you've used in the last 24 hours. And then there's something that we've termed, it's called IOPP, Individualized Opioid Prescription Protocol. And what that is that looks at the last 24 hours and it says, okay, if we're going to taper this down and allow them to, go home on enough, but taper it down once they're home, this is what we think that you would need at home. And then we have a discussion and we say, this is what we recommend, But, based on everything that you've learned today about, what to expect in terms of pain, but also the opioid epidemic in general, and, what do you want to do? And it's been really, really exciting, and it's been really interesting to talk to moms. The study is beneficial to moms because we know that, if this IOPP, or potentially beneficial, I should say, we know that if moms continue to use opioids regularly at 1 week or after 1 week post-cesarean, post-discharge, there is an increased risk for persistent opioid use. So that's one way that we're hoping that, if this IOPP is found to be, equal in terms of managing pain, it will benefit the mom, these moms directly, but then also for families and society. So you think about, leftover tablets. If you prescribe someone who hasn't used any opioids in the hospital, she's sent home, let's say, with 30 tablets, but she's not going to use those, then you have those potentially 30 tablets left over that could potentially get into the wrong hands. So that was that's kind of an overview of the study and what our thoughts were when designing the study. So for our moms, they are assigned to one group, which is a standard, but which is, legal in all the states, and it's considered to be a, lower standard for some states, but it's good, versus this individualized approach. And Deborah can speak to this as well. We've really had a lot of good interactions with the patients who we've talked to in consent, but also who've been in the randomization process, and those who are randomized to the IOPP. And they've just said that they're really, happy to be a part of their care. They are happy to be a part of the decision-making process and the conversation. A lot say that, in the past they were sent home with a prescription and they filled the full prescription just in case, because they didn't know if they would need it or not. Versus, this, which we say, okay, you look like you may need a couple to last you the next couple of days to taper off. And then that's something that's more comfortable for them, because it's not going home with 20 tablets, it's going home with 5, if that's what their decision is. So it's really helped them in terms of comfort. And this also makes them, feel more comfortable at home due to concerns of having leftover tablets, or, if I need a refill, how am I going to do that? There's just a lot of pieces that are involved. We've also found that some patients, they're not even aware that they've been taking oxycodone during their stay, because it is just such standard of care. It's like, okay, here are your pain meds. What's your pain like? So it's been really eye-opening for us to be able to talk to them about this and encourage them to be a part of the conversation, not only while they're in the hospital, but when they go home and what they go home with. And then a lot of the patients, so when we talk to, and part of our intervention piece is just discussing the opioid epidemic as a whole, a lot of them do refer to someone that they know that has struggled with addiction. So I think that this is really hits home for us in Ohio with a lot of, we've got a lot of opioid use and misuse here. So it's been really exciting for us to see that we are, we didn't get to talk to these moms in advance, but we are empowering them through the study. So, in summary, we get to engage patients, and it's beneficial and empowering. And we're hoping that if this IOPP, this individualized approach, if it's as effective in controlling pain after discharge, it'll be an easy and effective way to not only empower patients and to make them, part of the conversation and part of their care, but also to reduce the number of leftover opioids that are potentially get out in the community, which will help the mom and these families, but also our community and society as a whole.
Thank you so much, Anna. I really appreciate the overview. Next, I'm going to call on Kevin Charles, who's part of the NIDA Clinical Trials Network, to share the work that he's been involved with.
Hey, everybody. Good afternoon. My name is Kevin Charles. I'm a certified peer specialist and a recovery coach through the Department of DBH. A part of my job in the community is to help navigate people to healthcare services such as primary care, case management, substance abuse counseling, and medically assisted treatment. Over the past 2 years, I've been working on the Care First grant, which targets opioid crisis throughout Washington, D.C. I am a member of the Community Advisory Board, which is a part of the Clinical Trial Network. to advise Howard University for best practices. And those practices are for getting people in the community into treatment. I did help develop the questionnaires that will be implemented in these studies. And from my experience, I would say with helping people, I would say that I want to add on that I would suggest that the researchers be genuine, active listeners. And I feel like this will help guide their work in the communities. I also want to stress a key point that we should probably be able to relate with these clients. The population that we navigate doesn't really care how much you know until they know how much you care. So, you know, if we all can relate to that, then we all will probably have a successful way to be able to relate to these clients and also get work done with them. I joined the Community Advisory Board because I saw it as an opportunity to advocate for the population that I serve. I also wanted to give other peers insight on how to assist people in the community with opioid addictions. What being a part of this Community Advisory Board means to me is I feel like, first of all, the most important is I'm able to give my parents a return of their investment. When I say that, I mean that, you know, I was brought up in a house where, you know, mom and dad, you know, always, you know, on top of us, teaching us how to do the right things, you know, teaching us, you know, trying to keep us, you know, out of trouble, trying to keep us out of harm's way, you know, and even if it was just opening a door for a young lady, you know, that's just the way that I was taught. You know, so me being able to, you know, be out in the community and be able to be a service to people, I feel like, you know, my mom and dad is just, you know, smiling. You know, it's nothing else they can do but smile and be happy about the work that I'm doing. You know, also, you know, I feel like there's a lot of people that I wanted to give back in the community that, you know, I really didn't have the resources to do it, but now I have the resources to do it. And now that I work in this field, you know, I call me their plug. You know, I'm their plug, you know, anytime they need, you know, any type of medical assistance or anytime they need, you know, programs, whatever, I'm their plug and I feel like they can come to me. I also feel like it's one more opportunity to be of a maximum service to any human being, you know, and I know that probably come with not only, you know, just, you know, dealing around the opioid addiction and things of that nature, but also the healthcare field, you know, also, you know, just checking up on these people, make sure they have primary care doctors, you know, make sure they have physicals. A lot of time, people resort to drugs because other things are trickling down on their life, you know, and one thing that I realized, you can't really, it's certain things that you can't take in a hospital, even for pain, even for, you know, some crisis that people going through. It's some things that they just really can't take in the hospital. And it's only because their underlying health conditions, you know, they done probably got so far, you know, and their addiction that, you know, they stop fighting, you know, they let their body go, you know, they stop getting those checkups every 6 months, you know, and it's something just that small that, you know, I feel like our people is missing. And right now I just feel like I'm the opportunity that, you know, a person can come to me and if they need anything, you know, substance abuse groups, you know, a doctor, if they need an eye doctor, if they need to get they eyes checked out, you know, I got it in my network. They can come to me and see me for that. So, you know, that's what I feel like this means to me. And also, I just want to, you know, take a moment out just to, you know, thank you all for just having me. You know, it's a big blessing for me. This is a big stage for me. I appreciate the exposure. And, you know, I'm just ready to just continue to grow in this field. So I appreciate you guys for having me today.
Thank you so much, Kevin, for sharing all the great work that you're doing for our community. Dawn Edwards, can you share with us all the work that you're doing? Can we hear from you next?
Hi, good afternoon, and thank you so much for the opportunity to share with you. My name is Dawn Edwards, and I'm from New York City, Queens, New York, originally from Brooklyn. Woohoo! And I am a kidney patient. I've had kidney disease for the past 29 years. I'm currently on dialysis, and I've been a patient advocate for 25 of those 29 years. And that work has been absolutely rewarding to me because I get to share my experience and my perspectives with people who really need guidance and who need someone to listen to them who really understands the experience of the patient. And after all of those years of advocacy work, this is the HOPE study is my first um, time participating in a study or a trial, and I serve as a patient advisor. And I was a little hesitant about being involved with anything that had to do with studies or trials, and I just say that that is because of I would say history and community influence. Science doesn't have a great reputation. I mean, there's some absolutely fabulous things that have been done. We've advanced so much, as a nation in science and health. But some of the things that were less desirable seem to take precedence, and they affect the entire community. And after talking to some people that I really admire and get good advice from, I decided that it would be a good thing for me to learn and for me to grow and experience the whole study, trial, and science arena. So this way, as a person from the community, I can take the information that I learn and the experiences that I have back to my community and hopefully enlighten other patients and other people who have these negative stigmas and the mistrust in the science realm. And, hopefully try to debunk some of the myths and maybe smooth over some of the past history, because it's really important for people of color, for people in low socioeconomic status, for them to be a part of science. We're the recipients of the care and, the results of the studies. So I thought that it would be really beneficial for me to be a part of the HOPE trial, so that I could learn and share. So being a patient involved in a trial is an unbelievably rewarding experience. It started from the day that I walked in the door to the consortium, and Dr. Kimmel he was absolutely fantastic. He told everyone in the very beginning, the patient advisors are going to be actively involved and engaged, and we want you to treat them as equals and to listen. And that's something that we've heard in uh, the past three speakers, as a matter of fact. It was Kevin, Dr. Baker, and Dr. Volkol all said, how important it is to listen to the patient. And we are the ones who are experiencing the pain, or we're the ones who are experiencing the dialysis. So we can give valuable insight into how to direct the studies in order to be able to recruit, to be able to attract the patient to participating in the studies, and also just to provide support to the members of the consortium uh, as they learn more about the dialysis patient or the pain experiences that the patients are having. So as patient advisors, we have a lot of different roles within the consortium. We participate in absolutely everything that has to do with the trial. We started in the beginning with the informed consent. We worked on that together as a group. and we developed, or we talked about the type of language that needed to be used, what information was necessary, what was too much information, how it needed to be worded so that the patient could understand the informed consent. We worked on flyers and information that was going to be given out to recruit patients to the trial. Uh, and that was really the input of all of the patient advisors, as well as the leaders of the recruitment committee. In addition to that, we also did an introductory video so that that could be shown by the recruiters, so that the patients who they're attempting to recruit can not only look at a flyer, but they could actually see a video of us describing our experiences as patients who have experienced pain. And they could see that it's not just one type of patient. It's all types of patients. It's patients that look like you, that are involved and engaged, and that turned out to be a really rewarding experience as well. And we really hope that after patients see the video and look at the flyers, that they will see that it is patient-led, patient-driven, and we're hoping for a great deal of patient engagement as a result. One of the things that I think is really important for recruiters to be aware of, or people involved in studies and trials, is the patient experience is absolutely necessary. We see things in a way that is a little different from the scientists or the leaders of the groups, because we actually experience these treatments, or we're actually the ones who are recipients of the medications, or we're actually the ones who experience the pain. So sometimes we can look at things in a way that we're focusing on a goal, but you don't actually see the person in it. And the patient is able to bring that perspective into the study, and it humanizes it. Whereas the study participants are not just numbers, but they're actually people. And that's a really important part of recruitment and working with patients to get the information and the participation that you want, is to recognize them as a human being. In the dialysis field, there's very unique circumstances. These people receive treatment 3 times a week. They have special needs. They have, different levels of pain and discomfort. And we in the HOPE trial are putting together a discussion that we're going to have with the recruiters and other members of the consortium, to explain to them and to give them a little taste of the dialysis experience, so that when they do go into the units to attempt to recruit patients into the trial, they'll be a little bit more familiar. Some of our members have been in the dialysis field for years and years, so they already know, but there are some who aren't quite as familiar. They may not be familiar with the dialysis center, or the bells and the whistles that are going off, or patients being in pain during treatment, or a patient's blood pressure dropping during treatment, or a patient just saying, you know what, I really don't feel up to it today. And it might just be that day, but you can go back to them maybe another day when they're not having a rough time. So I really think that all of these things have taken a lot of thought, a lot of care and concern on behalf of all of the members of the consortium. We all work together, and the advice or the support that is given by the patient advisors is really listened to. And that is empowering to me as a patient. I have the opportunity to lend my voice and my experiences, and I feel so valued because I'm understood and I'm listened to, and the necessary adjustments are made. You know, sometimes we as patients may say, you know what, that's really not a good idea. I don't think that patients are going to relate to that at all. Maybe you need to try it this way. And you know, instead of getting a whole bunch of arguments or anything, we don't have disagreements. They take what we say and um they value our input. And I think that that comes from the way that we were introduced to the consortium in the beginning, and the leadership that that the consortium falls under. So there are so many ways that you can use different tactics to engage patients and to recruit them and to make them interested. But you first have to understand the community or the society that you are serving. If you're in an urban environment where it's mostly Black and brown people or people of Hispanic nature or whatever, everybody remembers the Tuskegee experiments. You can't act like it didn't happen. You have to understand it, accept it, and use your knowledge to be able to explain maybe why that's not happening anymore or why that won't happen again, so that people can um, get an understanding, and let them know that this research is very important, not just for right now, but for the people that are coming behind in the future. And we as patients can be a part of making the experience better for those who come behind us. So I think that those are very key elements to think about when you're approaching the patient to recruit into the study process. And as far as getting patients to participate in the consortium, I, I think that that is a really key component as well, because you need that patient experience and the patient advice so that you can framework your study around being attractive or being received well by the people that you want to help. So at that point, I'll stop there, and thank you so much for your patience and your attention.
Dawn, thank you so much. You have so much rich advice and experience and real lessons and pointers to share with our research partners on the webinar today. I think your perspective and really sort of guidance is right on. And I'm trying to furiously write down all of our lessons that we're sharing from us as patients and stakeholders to the researchers who are on our today's agenda as well. So I have, I think, 15 from your chat already, Dawn. So thank you for all the work that you're doing, and such an amazing group. I'd love to ask Amani Walker to share a little bit of her work and experiences in engaging patients.
Hi, good afternoon, everyone. Thank you, Jessica, and thanks for the invitation to speak. So I'm Imani Walker, and I am a mother in long-term recovery from substance use disorder. So this is a subject that's very near and dear to my heart. Most of my career has been in policy advocacy around family-centered treatment, maternal addiction, and ensuring that lived experience is at the forefront of policy decisions and systems change. So when I received the call to be a part of the community advisory board, it was one of those things where, even though, you know, I already had so many things on my plate, it was just too near and dear to my heart not to participate and lend any experience that I could lend to the process. So, you know, I was very grateful to be a part of it. you know, the goal of the Community Advisory Board and the clinical network trial really was to develop community-based interventions to get people into treatment. And so under that goal, what I really loved was the fact that Howard University got together this amazing, diverse group of community members with lived experience, folks who were leaders in the community, you know, everything from faith-based leaders to, you know, like the head of a community resource center. So you had this diverse group of community stakeholders. And I guess what I'm saying is, even though there was that overarching goal, I feel like a lot of time was really spent in hearing from us and the community in terms of what we thought was needed in the community. And obviously, you know, Dr. Vokal talked about the social structure and the importance of that and the importance of families. And I think what kept coming up was that there was, you know, an intersection of community needs, an intersection of community issues. And, you know, I think if it wasn't for that really diverse group, that's, you know, some pieces may have been left out. You know, I can remember in particular there was one board member who would talk about the importance of, you know, community financial stability and, you know, I guess wealth for the most part, issues of health disparity, racism, just all of the things that the community is facing. I think, you know, there was really a safe space that was created to bring up all of those things that we felt were important and that played a role and an impact that you may not think of initially when thinking about opioid addiction. So I was really grateful for that. I think the fact that that the team was Howard University, I feel like that was important in terms of community trust. You know, the fact that it was a HBCU, I think was a good thing, because there is this historical, you know, there's this historical mistrust when it comes to any research in the community. And we talked about that. We talked about that in depth. We talked about how do we, you know, acknowledge that, you know, be transparent about the fact that that exists and just deal with it head on. We talked about the stigma that exists. Just like Kevin said, when we developed the questionnaires, and I say we because it really was a collective effort, we, you know, down to wordsmithing it, down to making it culturally appropriate for our specific community. Well, that's not how we would say that. That's not the phrase we would use in terms of, you know, not only that's not how we talk about drug use, but just in terms of how our language flows, you know, here in DC. So all of those kinds of things were addressed, and we came up with that initial draft questionnaire. And then the board members, we participated in being interviewed. And so things came up in that process that helped us to tweak it even further. So I just wanted to say that the work that I do, like I said, has really been focused on maternal addiction. And currently, I am family engagement coordinator for a social emotional early development project at the Department of Behavioral Health here in DC. So my focus has been on interventions for, you know, very young children, and getting parents involved in making sure their voices are heard, and you know, that they're in the feedback loop in terms of the system of care. And so that's the work that I'm currently doing. That grant ends on March 31st. And then I think there's a good possibility that I will be moving on and working directly, you know, when DC just got a lot of money to address and combat our opioid problem here. And so I may be working directly more related with opioid issues. But like I said, you know, there are so many issues that intersect within the community that directly impacts the opioid problem here in our community. I think I may have actually, oh, this is the other thing. I was thinking I may have covered everything, but the other thing I wanted to say that I really appreciate about the process was just the will. This is something that comes up in the work that I do with families, and specifically with leaders in the community and family leaders in the community. They feel like they're often part of boards, you know, that they are part of all of these kinds of advisory boards where they want community input, but that they're never really given credit for the work that they do. Like, this is something that's voiced a lot. And I can say that I feel like this team has done a great job of really allowing the board members to have ownership, not only of the process, but of the final product. And as we moved forward, after I forget how long, but you know, some length of time, it just kind of, I mean, I don't know if this was initially the intent, but it organically became that one of the board members should also co-chair the group. And so I have no idea how I became the first co-chair, but it happened. And like I said, because it is my passion, it's just one of those things that I could not say no to. So it's been really an honor to serve in that capacity. And, you know, I just think that just speaks to the whole process. The other thing I want to say really quickly is I think that this board has been really creative and has really listened to the board members in terms of being creative and how it is that we engage the community. And so one of the things that has happened is that we have started, and I'm probably not the best person to speak to this, but we have started assessment and screening and other services directly in the community and not in the usual places you would, you know, think you would find those kind of things happening, like maybe in a clinic or something, but at a local church and at a community resource center. And so that's part of the being conscious about, you know, making sure that folks can access the information and the help that they need in a place that is non-stigmatizing and that, you know, they can readily access. So I think that's what I wanted to say. Thank you.
Thank you so much, Imani. You do such amazing work and such great feedback. I'm glad you, even though you're so busy, I'm glad you took the time to serve on the advisory council and give all of your input and expertise. And I'm also furiously writing down all of your suggestions and lessons learned. And last but not least on our panel today, we have Chris Beasley. Chris, can you share a bit of your work with us?
Sure, thanks, Jessica. I'm Chris Beasley. I'm the co-founder and director of the Chronic Pain Research Alliance. I myself have had chronic pain for 30 years since I survived a near fatal accident when I was 15. I spent some time, have a science degree, spent some time doing neuroscience research at Johns Hopkins, and have spent the last 25 years or so advocating for rigorous pain research. And our initiative in particular really works to understand the connectedness between different chronic pain conditions and other conditions that overlap with pain. So like sleep disorders, mood disorders, and really focusing on the whole person and not just piecing apart this condition or that condition or this symptom and that symptom, and really understanding that, we experience illness and wellness as a whole health or whole body and experience, right? But so oftentimes our healthcare system is just fragmented and doesn't address our health situation in that respect. We also work on knowledge translation. So we really want to make sure that we get information, new research findings that are coming out on chronic pain and related conditions into the hands of clinicians and people who live with chronic pain right away. So we know there's about a 2-decade gap from the time high-level science is funded until the time it actually gets down into the clinic and really impacts patient care. And then we also work on research and development, so to advance therapies and again, whole body or whole person models of care for people with these conditions. And an area that we obviously work in very much is patient engagement, right? So really advocating for the role of including people like ourselves who have lived experiences with these conditions and that of our family members and caregivers to really impact science. It was interesting when I first started doing clinical research in the late 90s in pain, and I think this is true for pain and many other conditions. It's considered such a subjective experience. We ask people, how much pain do you have? You rate it on a scale of 1 to 10. And investigators really consider that to be subjective. We don't have like a blood test or some other test that we can do to make sure that actually you have the level of pain that you're saying that you have. And I was taught very early on, when I was being trained to conduct science, you don't engage with the patient. The patient is subjective and it would influence the integrity of the science that you're conducting. And we've really come a very long way since then, and really understanding that clinical research is really only successful when you include, the perspectives of people who are living with the condition, their caregivers, and other types of stakeholders. And I would just really encourage, there's been so much that's already been presented by the other panelists, so many themes that are very important. But I guess I would just really emphasize and challenge the research community. As Dawn said earlier, research is conducted to improve the lives of people who are suffering with a certain condition, right? And a lot of times science is done, papers are published, and it just is kind of out there, but it never makes its way to actually being implemented, right? And disseminated to the people who actually need it and will use it. And so I just really challenge investigators to think about your science in a way where you start with the end goal in mind. Normally we start the other way in science. We start thinking about, okay, what is my important research question? What are my study aims? And then how am I going to conduct the study in order to find out what I want to know, right? But really think about, 5 years from now or 10 years from now, if this science is conducted, what do I hope it will do? What do I want? What kind of impact do I want to make? How do I want to see people's lives or healths changed by the science that I'm conducting? And then really think about, okay, who are those stakeholders that I need to engage in order to get there, right? So it's patients, it's caregivers and family members, but sometimes it may also be clinicians. Maybe you need to ask primary care providers, what do you see in this patient population? What information could I give you that would be really helpful in terms of caring for this patient population? Maybe you need to engage with insurance providers and payers to understand what kind of data do you need in order to make coverage decisions for this patient population. Right now with pain, one of the major things that's experienced is that, there's coverage for drugs, or medications, but there's not a lot of coverage for other non-pharmacologic treatments like massage or yoga or other types of wellness therapies. And so we need to understand, okay, why doesn't insurance cover that? And what type of data do companies need and payers need in order to change those coverage decisions? Because once you've collected all of that data, then you can go back and design your study in such a way that it's really going to maximize what we learn from it and what can be implemented from it. If you're already in year 3 of your study, and then you start talking to payers or patients or family members, you can't go back and redesign the study, right? The only thing you can do is complete the study you're already in and maybe redesign another one in the future. So just really being thoughtful, and there was a question in the Q&A about, is there guidance and resources available for investigators? And in some areas like pain, patient engagement is kind of a newer area, but there's other conditions like cancer and HIV that have had engagement around for a very long time. And there's resources that have been developed to help investigators understand and really learn from others who have been doing this in terms of how do we do this and how do we do it well. Corey has a lot of resources that are available in terms of doing that. And the last thing that I would just say, just following off some of the comments that Imani made about value and recognition of the stakeholders that are engaging in the planning and conduct of your research, is to make sure that the communication is bi-directional, right? You don't want to bring people in, ask them a bunch of questions, and then they never hear back from you again. They never know whether they influenced the research. Did it help? Did it not help? But really kind of developing partnerships and not just so much asking questions and getting information from people, but how do we partner together? How do we talk together? How do we communicate with one another really to advance this so that there is both a meaningful exchange on both sides, because both parties learn and grow when they engage together. So I think I'll leave it at that. Thanks, Jessica.
Thank you, Chris. And I know we are going into a Q&A session a bit with having some selected questions that we're going to present to our panelists, but I wanted to take a minute to do a recap for all the researchers on the webinar with us today and just do some highlights and some thank yous and recognition of this great feedback from our patient panel, our patient and stakeholder engagement panel. Anna shared with us that the importance of making the patients part of the conversation and what we can learn from shared decision making. I think that was really helpful feedback. Amazing feedback from Kevin, including a quote, which I'm writing down and I'm going to make a t-shirt out of Kevin that says, we don't care about, speaking of both researchers as well as potentially healthcare providers or clinicians, we don't necessarily care how much you know until we know how much you care, right? And so making sure that that is transmitted and conveyed to patients and those involved in research is really important. I also loved sort of you're setting this up as how our peer navigators can be sort of the healthcare plug and sort of a way to engage not just in acute needs, but sort of long-term healthcare access that we can build into our systems. Amazing feedback as well from Dawn. I'm going through the highlights in our lessons list for our research partners. Among them, and we heard this a bit from Imani too, that we need to address the mistrust of research and science that exists within the African American community in particular, but not by avoiding the topic, but I think as Imani said, addressing it head on. Dawn, I think so eloquently spoke about remembering and acknowledging the Tuskegee experiment and explaining why that won't happen again, and sort of addressing that as you want to engage particularly the African American population in research is really important. We talked about that a bit on some of our previous calls, and I think there was some great feedback there. I also love Dawn's recommendation about how you introduce this work and the leadership, how they begin this is so critical. To set up that their patients will be engaged meaningfully, they'll be listened to, and at the table. I think Dawn even shared a story once about one of the key researchers making sure that all patients were at the table with researchers as sort of equal part players in this conversation and dialogue. I think we also hit on the tone of the researchers and clinicians at the table being very important to set expectations that the patients will be engaged and listen to. We also heard from several of our panelists about the importance and sort of how helpful patients can be in input on flyers or introductory videos for recruitment, advertising, and to make sure that there's feedback from individuals with lived experience and from patients to sort of inform those pieces, which will make the research more successful. I also loved Imani's feedback about making sure that you create a safe space. When you start a conversation about treating opioid use disorder, you may overlook the fact that you are going to address issues of racism, of health disparities, and creating a safe space for all patients to come to the table and share their experiences is really important. And also mention the importance of materials and other components in research and making sure that they are culturally appropriate and relying on your patient and stakeholder partners to help provide that feedback. I also loved Amani's point on giving credit to those that participate so that their work and the final products are sort of attributed to the patients that come to the table. And also Amani's point about potentially conducting assessments and screenings in community-based settings, such as a church or a local community center, instead of just a healthcare or university setting or some type of setting that may be more stigmatizing than something in the community. And then Chris, amazing feedback and recommendations about the need to focus on the whole body and sort of the connectedness of all of these conditions and how patient advocacy groups and patients can help with knowledge translation, even addressing that and helping to bridge the gap between research and practice. I loved your point, Chris, too, about closing the feedback loop. This is also would be a recommendation from Addiction Policy Forum, and I think we go and also sort of add that closing the feedback loop doesn't necessarily mean sending us a copy of your scientific journal article, which is not sort of written in a way that's accessible to all of us. I think having ways that the research that we participate translated into something that is accessible by entire community is really, really important. I also think that Chris made a point about ensuring proper dissemination, again, getting at that research to practice, bridging that, but making sure that researchers and sort of challenging researchers to think about the impact of patients, but also who needs to be engaged and who needs to be involved in that dissemination strategy for your research so it can reach the right audiences and have the right end goal. So I think that's 20 lessons learned from a pretty amazing panel as I think a starting point and a really important set of recommendations and lessons for our research partners. And I'm really grateful to NIH and to NIDA for all of your work focusing on patients and these our amazing panelists who do so much to create this bridge and improve engagement of patients both with opioid use disorder and pain. We'll also keep writing these up and writing down additional lessons as this work continues. I think that's our recap of the top 20. I thought it was going to be like the top 10, but it ended up being the top 20 recommendations from your amazing patient engagement leaders. And I want to thank each of them for this amazing feedback. Danielle, did you want to shift over into some Q&A?
Yes, that would be perfect. Let me pull up a few of the questions. It was a wonderful panel so far. And one of the questions I will ask is, what are the primary concerns from patients when they engage with new technology? Anyone can answer that if you've had to use technology.
I know out in the field, what I do is, since I'm working out in the field, I don't sit at my computer at work and do my work. So a lot of times for me to enroll these patients or clients, I carry around a tablet. Now the tablet has a strap that can go around my shoulder, and what it is, I'm up at the patient, and now if I can sense that this is an uncomfortable thing for the patient, then immediately I'll, put it away. But normally when I have my tablet outside, I don't know, what kind of, picture that gives the client, but I do know that the client gets a little uncomfortable. Also, asking the client too much information while not in the office. Now, if we was in the office, it's cool to ask a client, you know, about his date of birth or social security number and things of that nature, right? But a lot of times it seems like for some people it's kind of weird, and you know, like I mentioned before, you know, they really don't care how much you know until they know how much you care. So if they don't sense that genuineness from me, you know, I don't think it's a, you know, a big possibility that I would probably end up getting, you know, all the information that I need from that person. And although we are into, you know, helping these people, and we don't want to, you know, ask them things to have them shy away and things of that nature. So what we try to do is we try to keep it, you know, discreet as possible. You know, we try to keep it, you know, on a relatable basis. And by doing that, you know, just asking, you know, common questions, you know, how's your day going so far? You know, is it anything else I can help you with? You know, just common questions that makes them feel comfortable, you know. But I know for a fact that one time when I'm in that community, if I got that tablet out sometimes, it kind of discouraged them. I don't know if they look at me like, you know, oh no, maybe you are part of some type of clinical trial, or you know, maybe you're a part of, you know, some type of, you know, professional business, but it really don't look like, you know, you're here for us. So a lot of times for me to go up and, you know, approach those, you know, clients or patients, a lot of times I can't even take my tablet or my laptop with me, you know, because they can't relate to that type of perspective. You feel me? So, you know, I do think that, you know, having that technology with you sometimes, I do think that is a big difference. It do give them a different look, you know, on the work that we come to do.
Thank you, Kevin, for talking about how it can sometimes create a barrier.
For sure, for sure.
Don, did you want to comment?
Sure.
No. I'm sorry.
I would just say that when it comes to introducing new technology, like in the forms of treatment options to patients or to the general public, there's automatically going to be that sense of mistrust, right? We're having problems right now getting people to sign up for the COVID-19 vaccine. There's just an automatic level of mistrust there. And people who need help need to feel safe with taking the help, or else, you know, we're already used to suffering. We're in pain, or we're having physical problems, or we're having issues, so we can deal with that. We already know what that is, but we don't know what this new thing is. So it needs to be gently explained, and with as much detail as that person um, can understand, and it needs to be explained in a way that they can see that um, giving something different a try may give you a different or a better result. And you know, I think that that's just the best way to introduce something that is new, and something that person is not used to, is by explaining what it is, and you know, letting them make the decision themselves that this, based on the information, that this may be something that could be helpful to me, and not selling anything, but offering a solution is, I think it's a little bit more advantageous.
This is Imani. Can you repeat the question?
Yeah, sure. What are the primary concerns from patients when they engage with a new technology? I think this is mostly speaking to how we are now in the current state of the world.
Right. So just to talk about my experience with working with what we call consumers, this transition that happened with the pandemic was huge. So for me, in terms of the work that I do with family engagement, it started out initially with me using the technology that we were already using. You know, we didn't just immediately switch. So for example, for some families who were working, they were already on email, you know, so I would email them. Other families prefer text, so I would text them. Within about, it didn't take long, I think about a month into the pandemic, because we were meeting in person before that. And so through conversations, we talked about what would be, you know, a viable way for us to still continue to have that level of connection. And while that was happening, and since I work with parents, the schools also went to virtual learning. So since the schools were doing the distance learning, the parents were having to negotiate being able to get on the school's platform. And so that was happening in tandem. And so when we started having our sessions on Zoom, the parents at that point had become familiar because of what was happening with the schools. But everybody wasn't necessarily the parent of a child, you know, a school-age child. And so for those parents, literally some of them would, you know, call in. And then the other parents would be, well, you know, you have a cell phone and you can join us through your cell phone and you have to download the app and this is what you do. And so it was a lot of just supporting each other and being really patient with, you know, and being clear that some people were a little more advanced than the other folk, but again, not, you know, making it a safe space, you know. And we literally focus just on support, because, you know, I think about the work that Jessica does in terms of the let me get the name of the group right, because I wrote it down, Addiction Policy Forum. Our work before that was all about this policy work that we wanted to do. The pandemic hit and it was all about self-care and supporting each other. And so that made it easier to introduce. And then this is the last thing I wanted to say about that. From the agency's point of view, because of privacy, they wanted us, everybody on Zoom. I mean, I'm sorry, not on Zoom, WebEx. The parents was like, we can't navigate that. That's difficult for us. And so having to support the parents and stay where they were, meet them where they were, and then eventually move them to the platform that made more sense for the agency, that was something we had to negotiate. So yeah, I just wanted to speak to kind of what happened for the parents. And they also were moving all of their doctor's appointments, their mental health sessions, their sessions for the children who had learning disabilities. Everything was moving virtual.
Awesome. Thank you so much for that perspective, Amani. Kind of moving into building up on kind of what Dawn was saying when it comes to stigma and mistrust, and kind of a few of the questions that were submitted previously. From you guys' opinion, has there ever been any hesitation from patients, peers, or advocates to join and participate in clinical trials because they wanted their experiences to remain anonymous and to not be stigmatized by their participation? And if so, how do you engage those? How do you recommend engaging those communities to avoid re-stigmatizing them and really getting them engaged in the research process?
I think that letting a patient or a participant know that they are safe with you is paramount. You have to establish that relationship. You have to reassure someone that that this work is necessary, it's important, it's to help you and others, and you're safe here. I think that's just a really key element, because the mistrust is not going to go away. We can't ignore it. We can't say, oh, get over it, because especially in my community, we'll come right out and tell you, oh, I'm not going to be another experiment for you. So you have to really, like Imani said, meet people where they are and then build from that point forward. If a patient wants to be anonymous, maybe they feel not only that they'll be stigmatized, because we all know there's been studies that show that African Americans can endure more pain than people from other cultures. I mean, there's so much stuff out there, misinformation, myths, as well as some information that, that is really happening. And I think that once you acknowledge what has happened in the past and try to reframe that and make that person feel that they're valuable, safe, and like Kevin said, is cared for, you may be able to break down some of those barriers. And then again, you have to accept when you're not able to do that as well. And, maybe just move on. But if someone wants to be anonymous, they may be concerned about the backlash that they'll get from other people around them. Because some of my experiences have been when I've decided to try something new or try something different, you hear from other patients, oh, you got to be crazy. I would never do that. Or, this is going to happen. I heard Mr. So-and-so tried that and now they're dead, So you have to definitely meet people where they are and try to reassure as best as possible and provide them with factual information, even data, whatever it is that you have to make a person feel safe.
Yeah, just building on that, I would say that it's really important to be totally upfront about how the data that's collected in the study is going to be used and the access that the person who participates in the trial, whether they're going to have access to that data or other data that comes out of the trial. I think that's really kind of key importance. I mean, obviously in many clinical trials, you can't participate as an anonymous, you can't be anonymous in a trial, but as Dawn was saying, like building about, you have to meet them where they are and start in building trust. And again, that goes back to the bi-directional communication. And also really engaging with them and letting them know why are you doing this study as an investigator, right? Because addiction is so stigmatized, pain is so stigmatized. And actually, as research moves forward, it helps to legitimize these conditions and reduce the stigma, right, that's associated with them. I mean, in the very beginning, pain used to be thought of as just psychological, it's in your head. And now as we have MRI studies and other technologies that have gone forward, there's actually evidence to show, no, actually the brain and central nervous system of people who develop chronic pain is different than people who don't go on to develop chronic pain, right? And it helps to legitimize the experiences of something that's otherwise very subjective. So I think when you, as an investigator, it's not just important to tell people what you're doing, but why are you doing this? Why have you chosen personally to study chronic pain or addiction? What do you hope your career means in 10 or 15 years? How do you want to help people, in this population? Because, as Kevin said earlier, people don't know how much, they don't want to know what you know unless they know that you actually care and that you're just not another number in one of their academic studies.
Couple
items. I just wanted to just say one last thing about what Chris said. One of the first things that was discussed when we started the HOPE consortium, one of the patient advisors said, you know what, I don't think that people are going to buy into this because they're going to be afraid that you're going to take my medications away. And then I'm going to have to deal with pain. And, that's a really important piece. You want people to change, and change is not easily accepted. And, the participant needs to know that if you don't want to do it, you don't have to. Or if you want to go back to your medication, you can go back to it. Or they just need reassurance that they know that they will be supported at every aspect of the study, all the way through to the to the end of the trial.
Danielle,
I'd like to jump.
I would just quickly add a couple things from our perspective. When it comes to patients with an opioid use disorder, I wish we lived in a world where there wasn't stigma or real discrimination that comes from having an OUD, but we're not there yet. And so being really, I think, clear and transparent about if it isn't anonymous and if there are ways to identify, whether it's a clinical trial participant or you're going to be somehow public facing as a patient with an opioid use disorder, to make sure that they understand the risks that we potentially are sort of are facing, particularly with addiction and all the stigma around addiction. I also agree that creating a safe space is important, but also creating a place where you feel safe and respected, which also means including patient feedback on multiple parts. I have one example for the researchers tuned in. Lots of interest in adding severity indexes and information about SUD addiction history, but then really taking the time to sit down with the OUD patients, because repeating that information can actually be triggering and difficult, and talking about some difficult topics. And if it does come up, making sure that there's wraparound support. And the other item we hear from our patients is to have check-ins and folks that are doing that sort of feedback loop. How are you doing? Not just hearing when it's time for sort of the next research phase or the next input phase on the research end, but making sure that there are some support infrastructure pieces that are built in for those patients, particularly with a substance use disorder. That builds trust, it builds safety, it builds respect, and it makes sure that there's no unintended consequences from research participation.
I just wanted to add on, I think that one of the biggest concerns with, these patients, these clients, consumers, I think one of their biggest concerns is the way we role model ourselves. I would say for a person that's in the community that been through so much, been drugged through the mud, been through incarceration, and I'm not talking about me, I'm talking about a client at this point, went through rape, mental abuse, verbal abuse, who really would they be to just, come into any place and listen to a person and just, put their trust in that person? I don't think it probably would have ever worked like that. I feel like if these people haven't seen us be, the most upstanding role model in the community, or, a person that they can come to in a time of need, I feel like it's automatically no trust there. I want to piggyback off the vaccine mistrust that we're going through right now. I am a part of the vaccine team, and one thing that I realized in dealing with these clients that's coming up here to take this vaccine, the mistrust is really big, because these people really, 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 really don't know what direction to go in. And one thing about mistrust is these people that have been through so much in their life, meaning before they may have trusted someone, but once that trust has been broken traumatically to the point where these people is, experiencing, bipolar and, all these type of mental health things, when they get to the point that these people really don't have a sense of direction and who to trust, why would they just automatically just come and sit in front of us, and just because we say that we know what we talking about, they would trust us? It just don't work like that, but for a person to see that a person is an upstanding a citizen when he's outside of work, for a person to see that a person when he's at work, he's always been a caring person, that's the person that I want to put my trust in. That's the person that, I feel like, well, he looked like he's always the one that's helping people. It seemed like the people come up, more successful when they, go and, get whatever it is that he has for them. you know, so I want to be that person, you know, and if we're not that person, then it's hard to build trust. And not just for a person that's just, you know, just out in the community and, you know, only might want help with a primary care physician or things in that nature, not for a person that's just, you know, addicted to, you know, substance abuse and things in that nature. I'm talking about for people that really doesn't even have a problem, that really don't need your help, but they came to this specific space because at this time they need a COVID vaccine. Now they don't know what this vaccine may do to them, but you know, one question that a client always asks, they always ask, have you done it first? That's what they always ask. Have you done this? As long as you are a role model, they will always be able to trust you. You know, when these clients come in here and they ask me about this vaccine shot and, you know, what does it do and you know, how is it affecting people and things in that nature, it's because they don't trust what the news is saying. Obviously, you know, they didn't have to ask me, but for some reason they asked me. They felt comfortable with asking me, you know, and it feels good for me to be able to give them an answer and for me to feel like, okay, he's even listening to what I'm saying. So maybe somewhere along these lines, he feel comfortable with talking to me and he trusts the guidance that I'm giving him. So, you know, I just wanted to piggyback on that and let you guys know that these are real life situations and this is happening right now today. And you know, me being a part of, you know, the outside, you know, of the person that's thinking about, you know, mistrust or thinking about how a person misused them before and things in that nature, I feel like, you know, it's just, man, it's a breath of fresh air, because I know at one point I didn't trust nobody, you know. And being as though, you know, the government have, you know, such history with, you know, doing things that, you know, the community or, you know, our people didn't agree with. Yes, it's hard to trust a person. But now if you're a role model in that, you know, and if you're actually doing this, you know, what other choice does they have to trust you? You know, I actually done it. I actually been through it. Yes, I've seen that. Yes, I've done that before. Yes, I can show you how to overcome that. Yes, I can show you how to maintain that. You know, it gives them a different outlook on things. Vice versa, you just giving them a discrete answer and they don't know how to formulate a plan behind it.
That's excellent, Kevin. I think that you were speaking to humanizing yourself in the role, and
Sure.
I think ultimately that seems to be one of the big themes that have come out of this particular panel with stakeholders and patients. And we really do appreciate you guys' input. You guys are the experts, and I think our investigators have learned a great deal. I'm going to transition now to Dr. Paul Kimmel, who will help to moderate the second half of the meeting, where our investigators who have been listening to your discussions will come forth and really talk about some of the work they've been doing to engage their communities.
Thanks, Danielle. Welcome, everyone. We have a panel of distinguished researchers who have enhanced patient engagement in their studies. I'm going to ask each one of the investigators to spend about 8 minutes to both tell us a little bit about yourselves and tell us how you've incorporated the patient voice, the community voice in your work. Hopefully you'll tell us about the good as well as the bad. You'll tell us about your successes and your challenges. And I'll try to keep time to keep us on the mark. Our first speaker will be Dr. Lauren Brinkley Rubenstein, who's from the University of North Carolina at Chapel Hill, where she's an assistant professor of medicine.
Thank you. Soon to be associate, hopefully. I am really happy to be here today and talk about some of the work that we've done. All of my research is really at the intersection of incarceration and health, and thinking about the criminal legal system and its impact on health outcomes, both in the immediate and over the life course. I'm involved in 2 Justice Community Opioid Innovation Network grants, one in a jail setting and then the other in community supervision, so people in post-release supervision, parole, or probation. So most of the work that we've done is really thinking about how to connect with and collaborate with people who have been in the criminal legal system. And I'll just say one note at the beginning, which goes toward patient engagement and respecting the humanity of people that we work with, is we tend to use people first language in all of our work. So we don't use the word inmate, offender, et cetera. And so we use only people involved in the criminal legal system, people who are incarcerated. And I think that language helps to build trust in the way that many of the previous panel members were talking about is really imperative. And so that's just one technique that sort of came to mind. Yeah, we really do try to use just people and think about people's humanity first. All right, so maybe next slide. So in our studies, we've tried to build in some more structural, some infrastructure type techniques that we think help us to engage with the community and make sure that it's not a bunch of people in academia making decisions about what's best for people who are incarcerated. And they're really helping us come up with what health outcomes are most important, how do we address those, what are the barriers that might exist working with criminal justice agencies, finding people, retaining people in our studies, et cetera. We always form a community advisory board. This is not new to anyone, but I think what we really try to do is be intentional about the proportionality of the community advisory board. So we do have sometimes, you know, like one representative from a prison or a justice agency, but a majority of the people who sit on our community advisory boards are people who have gone through the criminal legal system or have family members that have. So really have that first person experience about what it's like to be incarcerated, to be on community supervision, et cetera. And we tend to involve them in some of the decisions that we're making relevant to research practices, both at the beginning of our study period and as time goes on, and then consult with them as tricky issues come up or unexpected problems. You know, we also have one of those Radix grants, so we're doing a lot of COVID testing and vaccine exploration in prisons and jails, and our community advisory board is really important in that context of an ever-evolving situation where we were interested in testing, we're still interested in testing, but now how does testing work in the context of vaccines, et cetera. And so I really think utilizing community advisory boards, making sure that they are representative of the communities that you're working with is really imperative. We also, in all of our projects, build in preliminary data collection, either as an aim, and usually as an aim, and also a prior to grant submission data collection activity. And this helps us to refine our research questions to understand what might be feasible, what might not be feasible. And the stakeholders that we're usually interested in talking to are people who have been incarcerated, are currently incarcerated, and sometimes people that run justice agencies that are going to know how a program might work. And we really try to hone in on, you know, what are the retention and recruitment activities that are important to this population? Where might we lose people? What's the kind of location information that we want to get from people so that we can find them later, et cetera. And then really important to this effort is that we do try to hire people on our teams, people who have been incarcerated. And so, you know, we include them as collaborators in our research activities. We have community advisory boards in which they sit on, but we also integrate them into our team. And I think this is really important because there are lots of barriers to employment post-release. And so we're also trying to make a dent in that and create guidance around, you know, how do you get around university regulations relevant to hiring people who have been involved in the criminal legal system and have become in some ways experts about how to navigate those systems. All right, next slide. And then I'm just going to talk a little bit about some of the work that we've been doing in COVID, where there have been extra challenges relevant to recruiting and retaining people who are incarcerated. And so we have a lot of studies that we're right in the middle of recruitment when COVID created a shutdown, and we had, you know, a ban on human subjects research those are gone now, but we have to be creative, whereas we might have previously been able to go to a community supervision site and recruit in person. We're not able to do that anymore. So we've been recruiting within existing participant networks, and that includes paying people to refer friends, and that's been quite successful. And so thinking about current participants as agents of recruitment. And we've also designed a bunch of remote recruitment strategies. And I think that it's really important to focus here a little bit because, if there are lots of barriers to e-consent processes for folks who are just getting out of incarceration, right? They may not have a phone, they may not have access to Wi-Fi. And so we've had to think about creative solutions there. And so in some studies, we've looked into a waiver of documented consent. In others, we've thought about, mailing consents. We have some e-consents where, we have programs that easily work as a text message so people can utilize it that way rather than having to go to a website. But I think it's worth mentioning that being creative and knowing whether folks have access to technology is a really important recruitment, recruitment technique that you have to stay tuned into. And then when it comes to retention, I mentioned before that we've done some incentivizing of people to refer other people into the study, and that works as both a recruitment technique, but it also encourages people to stay in touch with the study and stay in the study because if we're, creating this relationship with them where they're helping to recruit, then they also feel more invested in the study. We also we have this really robust locator information sheet that everyone fills out. And so we've got lots of contacts that people have given us consent to reach out to in the fact, if we lose them. And so we've started paying people to help as locators. I mentioned robust locator forms. We're doing that. We ask lots and lots of questions around both contacts and then also where people might hang out, who are trusted people that they would allow us to talk to, et cetera. That's really important to get the very beginning of one study. And then we also have a COVID-19 sub-study where we're asking people who are on probation or post-release supervision, their experiences with COVID, how probation or post-release supervision has changed over time. And that re-engagement with folks to do that COVID-19 study has actually acted as a retention activity for us that's been quite important and good. And maybe I'll leave it there. Thank you, Dr. Kimmel.
No, thank you. You're keeping us on time. So you're a exemplar for everybody to watch. Thanks so much. We'll have time for questions at about 4 o'clock. Now I'd like to introduce Dr. Ardith Doornbos, who's a professor of biobehavioral health at the College of Nursing at the University of Illinois in Chicago. She has the privilege of saying that she's involved in 2 studies, one of which I provide oversight for, and her own study, the GRACE study.
Thanks so much, Paul. I am pleased to be able to share with you the hybrid effectiveness implementation trial of guided relaxation and acupuncture for chronic sickle cell disease pain. This is funded by the National Center for Complementary and Integrative Health through a UG3-UH3 mechanism. And in HEAL, it falls under the Pragmatic and Implementation Studies for the Management of Pain, or the PRISM. And the importance of being part of the PRISM is that we also have a wonderful collaboratory, the NIH collaboratory that all PRISM grants are part of, which I'll talk a little bit more about a little bit later. Sickle cell disease is a group of autosomal recessive hematological diseases, and over 100,000 people in the United States, mainly of African-American descent, are living with sickle cell disease. And unfortunately, a very common symptom experienced by people with sickle cell disease is pain. So what I'm going to do today is talk a little bit about 2 specific examples, just to highlight those examples for how we have engaged with our patient providers. Next slide, please. First of all, and Lauren talked a little bit about this, is patient input at the beginning of the study. And one of the ways that we had patient input in helping design this study was looking at complementary and integrated modalities. And what we wanted to do is find out from our patient population at the sickle cell disease clinic is, what interventions are you interested in? We also were interested in seeing what the prevalence rate of pain was. So a couple of the questions we had for 68 adults who basically talked with me, and Franklin, who was a fellow who is now attending in the sickle cell clinic, is number one, do you have pain? And we found that 2/3 of our patients coming to our sickle cell disease clinic responded yes, that they have pain. And it was the primary symptom impacting their life. So from this, we were able to glean that, oh, indeed, this is really where the focus needs to be, and this is where the patients really want the focus to be. The next piece that the patients said to us was, everyone used some form of complementary and integrated health modalities, which was fabulous for us to learn. And the other thing is that that they were very, very interested in having access to complementary and integrated health modalities. So then we said, well, you know, what are you interested in? And two of the therapies that they came back and said were relaxation, meditation, and acupuncture. So here you could see that with the patient input, number one, we were able to affirm that pain is really something they wanted us to focus on. And number two, they were able to tell us, hey, these are the interventions we'd like to try. Next slide, please. Now I want to introduce you to two specific groups. And these are not groups that are completely separate from each other, but really, if you want to think of them as overlapping circles. But in terms of what they do. First of all, I just want to highlight that I am very fortunate to be at the University of Illinois, Chicago. And one of the reasons is that we are a state-funded school. We also have a very strong urban mission, and we are part of the Chicago community around us. So coming from that as one of the really prime missions of University of Illinois Chicago, we have a great involvement of the Chicago community in our research. And one of the patient groups that we have is what's called the Patient Brigade. And this was created basically because of patients. They said, hey, we want to be involved. And we said, sure. And this is a patient stakeholder initiative created to reflect the diverse ethnic, cultural, and socioeconomic groups in the Chicago area. And the mission is to provide an active voice to patients and communities. It is guided by our principles of community-based participatory research. And the patient brigade, if you want to think of them, are really our outward-facing group. They review patient recruitment materials, provide advice on improving recruitment and retention rates, and they recommend appropriate means for disseminating information about research results to the community. Next slide. We also have a phenomenal group who are our citizen scientists. And in general, citizen scientists are defined as people who are community members that undertake scientific work. And our citizen scientists serve on protocol review boards. They recommend modifications to measurement tools. They recommend design changes. And they have an active voice in all phases of our research. And this, they feel, is very key. Well, not just them, all of us feel that this is a key factor to ensuring not only diversity and inclusiveness in clinical trials, but also in expanding the research of cutting edge cancer discoveries and other discoveries. Next slide, please. Now I'm going to talk about one other example of how the citizen scientists in particular informed our study. And this was our design iterations. We used a sequential multiple assignment randomization, which is called a SMART design. And the reason we use this is because they're adaptive interventions based on a patient's response. So our citizen scientists said, hey, you know, this is a really good design because it's adaptive to how we're doing. It compares sequences of interventions, and it's a systematic approach for testing clinical decision rules involved in sequencing interventions. And it considers some of the real-world clinical situations. So if you think about the last time you were in a clinical setting, what may have happened was, oh, you're experiencing pain, is what the clinician affirms, you know, when you say, hey, I'm an 8 on that 0 to 10 scale we talked about a little bit earlier. Well, let's try this intervention. And then we'll check back in with you in 6 or 8 weeks and we'll see how you're doing. At that 6 or 8 week check-in, what happens is you're either doing better, this intervention worked for you, or not. And so then we say, okay, what we'd like you to do is try something else. Next slide, please. And so this is exactly what we did. And this was our original design. And we started out with either guided relaxation or acupuncture. And then at the 6-week point, we said, how are you doing? And if they started with guided relaxation and they were doing well, we went, yes, wonderful. This seems like it's working really well. If it wasn't working, then we said, well, why don't we add in another intervention, which was acupuncture, or we'll switch you to a different intervention. Next slide, please. What happened with that was the citizen scientists said to us, you know, that's great. I'm glad you heard us about, you know, having an adaptive intervention based on our response, but this is a little complicated. Can we simplify it a bit? And so then what we did was we moved to, if there was the response, we said, yes, okay, this works. And if there was no response, we switched to the other intervention. Now, this is where coming into the NIH Collaboratory was so phenomenal for us. So what we did was we went to the NIH Collaboratory, the Design and Statistical Working Group, and we said, what do you think? And they said, you know, it's awesome. However, we're very concerned about the lack of scientific rigor or the loss of scientific rigor if you don't have that second randomization. Can you go back to your citizen scientists and patient brigade and talk to them a little bit more and say, you know, would it be possible if we kept that second randomization in? Next slide, please. And so this is what happened for our final design, is that in having the incredible input from the NIH Collaboratory Design and Statistical Work Group, as well as our citizen scientists and patient brigade at the table, what we were able to do is come up with including the second randomization again, but not adding on a second intervention because that was felt to be too much, but rather continuing with a longer dose of the same intervention or switching to the other intervention. So this is a wonderful example of how not only our citizen scientists and patient brigade influenced and were part of designing this study, but also how we really brought to the table and negotiated with the scientists as well to come up with our final design. Thank you.
Thanks, Ardith. Thanks for keeping us on time. Now, I'd like to introduce Dr. Megan Irby, who is a research scientist in the Department of Epidemiology and Prevention at Wake Forest School of Medicine.
Hi, thank you so much. So it's a pleasure to be able to talk with you all today, and I'm really appreciative of this opportunity. So I'd like to start by saying that the trial I'm going to talk to you about today is a little bit different from the others you're hearing about, and it's a bit different from the types of community engagement that I typically do, which usually falls in the category of community-based participatory research. But with that in mind, I think it can be really helpful to see the many different ways that community engagement can be incorporated into various types of studies. Next slide, please. So I'll briefly talk about the impact study, and then I want to talk about NCORE, the NCI Community Oncology Research Program, and how we've been incorporating community engagement and health equity into our trial. Next slide, please. This is just a brief mention of our academic study team, and I'll add that there are many, many other names that are not included here, and they're the folks that are keeping the plate spinning for all of this work. So we can go on to the next slide, and I'll tell you a bit about IMPACTS. So IMPACT stands for Internet Delivered Management of Pain Among Cancer Treatment Survivors, and it's a 5-year UG3-UH3 randomized controlled trial funded by the HEAL Initiative and the National Cancer Institute. Now, the IMPACT study offers the Pain Trainer program, and it's an automated and interactive pain coping skills training program that can be delivered directly to patients via the internet to provide broad access to care within settings that are most convenient to patients. Pain Trainer helps overcome the costs and the burdens of what you would typically experience if you had to go into in-person visits at a clinic. And it's particularly valuable, as you can imagine, right now during the time of the COVID pandemic, when folks are looking for more socially distanced ways to engage in healthcare. Pain Trainer is offered free of charge and was designed to always remain that way. So our study, IMPACTS, is testing the effectiveness of this 8-week Pain Trainer program for reducing pain intensity and pain interference among cancer survivors experiencing new or worsened pain as a result of their cancer or its treatment, as well as reducing the use of opioids for cancer pain management. Next slide, please. So one of the important strengths of this study is the infrastructure through which it's delivered. IMPACTS is being conducted through the NCI's Community Oncology Research Program, and it's this national network that brings cancer clinical trials and care delivery studies to people in their own communities. The NCORE network is the primary source of accrual to NCI cancer control symptom management trials and provides valuable data with great emphasis on patient-centered outcomes that helps to shape the future landscape of oncology research across the country. Now, NCORE features 7 different NCI-funded research bases, like the Wake Forest NCORE research base that leads the IMPACTS trial, and that provides scientific and statistical leadership for developing, implementing, and analyzing multi-institutional studies. Next slide, please. In addition to the 7 research bases, NCORE also partners with 46 different community sites that together are able to reach more than 1,000 clinical entities across the United States and its territories, with involvement from community oncologists and various medical specialists, and most importantly, the patients that they serve. It's important to note that 14 of those 46 sites are designated as minority underserved community sites that have a patient population comprised of at least 30% racial and ethnic minority or rural residents. And these partners play a valuable role in engaging and building trust with traditionally marginalized groups that historically have been absent or neglected in clinical trials. Next slide, please. So through this hub and spoke structure, the Wake Forest NCORE research base is able to then engage with thousands of patients across the country via those many community sites that I mentioned and their affiliated partners. And these partners are the key stakeholders in this structure that facilitates participation in this large national network. The model itself was designed to be mutually beneficial, as participating sites in turn receive resources to support their community-based clinical operations. And as a result of that framework, NCI has then facilitated the introduction of research advances into practices across the country, no matter their proximity to large academic medical institutions. So expanding clinical research beyond the academic environment allows those partnerships with more diverse patient populations treated in a variety of healthcare settings that can then increase the generalizability and relevance of findings. And I hope this speaks to one of the questions that was mentioned earlier about how can this kind of community engagement influence and make your research better. So when this research is carried out within community settings, it reflects the complexity of cancer care delivery. It engages community providers and research to develop care delivery approaches that can then be implemented within their usual clinical workflows. So Community engagement looks a little bit different, as I'm describing here, than more traditional models of engagement. But within the context of NCORE, the research team, we have really no direct contact with study participants. And instead, we're working more distally by connecting with the community sites who are primary stakeholders who conduct the research within those community-based settings. Next slide, please. So I can't tell you how many times I have been told that it's just not possible to implement community engagement and large-scale multi-center trials, but I hope you know that that's not true, because not only do I think we can do it, I think we can do it meaningfully. It just might look a little bit different. So the hub and spoke structure of NCORE allows a unique opportunity to influence a broad base of stakeholders and many different communities and the participants that they interface with. So through planning and engagement with those stakeholders, including feedback from the community sites, patients, patient advocates, and colleagues at NCI, with HEAL and with NIH, we can tailor decision-making processes and implement stakeholder-informed plans to enhance the science. And that in turn enriches our knowledge base to create this cycle of learning that is geared towards constant improvement. Next slide, please. So here's an example of what that looks like within the IMPACTS trial. It starts with this intentional focus on engagement and equity. And our team wanted to respond to real world health issues and began aligning the strengths of that pain trainer program I mentioned with the strengths of NCORE to address important gaps in the literature and gaps in cancer care delivery. But it's also important to note that that pain trainer program was developed after many years of engaging with patients in clinical operations and focus groups and multiple iterations that were informed by patient feedback and empirical research. And that led to the development of this research concept for IMPACTS that drew upon lessons learned from patient and provider experiences, evidence-based research, that then also helped to identify potential challenges and allow for the integration of key strategies to address equity, access, and gain the voice of the patient. Next slide, please. So at this point in that timeline, we viewed the research concept through a health equity lens following the Progress Plus framework. And this framework allowed us to consider health equity relevant factors that would then guide us in designing and implementing the study intervention. It helped to always keep these things on our radar. So this framework reminds us to incorporate the intersecting determinants of health into research designs and focuses on place, race, ethnicity, culture, occupation, gender, sex, religion, education, socioeconomic status, and social capital. Next slide, please. So as Ms. Dawn Edwards spoke about earlier today, she beautifully described the need to elevate the voices of patients and their experiences. So to try to do that and to elevate those voices of our stakeholders and the patients that we're seeing, we also incorporated a qualitative component with interview guides that were designed to better understand the experiences and perceptions of patients in the pain trainer intervention, as well as the experiences of those that might have been less involved in the study or those that might have dropped out, and the experiences and perceptions of the staff and providers at the local NCORE community sites. Next slide, please. In order to overcome access challenges, we also explored the literature and relied on feedback from patients to develop a tablet lending program. So given that internet delivered interventions are inherently limiting and that only certain groups are going to be able to participate in those internet studies, particularly groups that are already experiencing marginalization, this program was designed to provide regular and reliable access to both the internet and a compatible computing device for eligible participants that otherwise would not be able to engage in the study. Next slide, please. So once these strategies were all integrated into the concept, that concept and preliminary research plan was then presented to our stakeholders that was vetted at the NCORE annual meeting and during various webinars. And then we incorporated specific design elements known to enhance engagement and to reach historically and traditionally marginalized groups. So feedback from those interactions with stakeholders, we gathered all of that up and incorporated those concerns and enhanced our protocol before we submitted our HEAL grant. So now we hold weekly meetings with the research team, and we invite advocates and stakeholders to be a part of those meetings, and including experts to further enhance the design and meaningfully address issues of known importance to patients and communities and clinical providers across diverse settings. So following the launch of our study, and we've just really gotten started in late 2020, and we're still trying to gear up recruitment at the moment. This was all happening amid the COVID-19 pandemic. Obviously, we are holding bi-monthly meetings with stakeholders from the community sites, which is an inherent part of the NCORE model anyway. But we meet bi-monthly with the community sites to hear their perspectives on our recruitment materials, to make sure that they're going to be appropriate for their clinical settings, to make sure that our protocol still fits with what they are expecting in terms of how they should accrue patients or how they should be interacting with patients. And during one of our recent meetings, the sites expressed concerns over the ability to recruit patients for in-person assessments at a time right now when people are really wanting to socially distance. So we made modifications to our protocol to limit in-person and face-to-face interactions. And we have plans in place now to conduct remote visits and complete assessments over telephone and electronically via REDCap in order to prevent so many folks from having to come into the clinic and to help assuage some of their fears about potential infection. So just as Mr. Kevin Charles was talking about earlier, it's so important that we as researchers are listening and demonstrating that we care. And as such, this model relies on bidirectional and open communication and authentic engagement that seeks to really nurture partnerships and foster genuine respect for one another, and recognize that the true experts aren't necessarily the ones with the extra letters behind their names. The real experts are the patients, who are indeed experts in their own lived experiences. And they're often the talented and often under-recognized individuals who carry the work forward into the community.
Thanks.
Next slide, please.
Can you sum up now, please, so that we'll
Absolutely.
have for a break?
So on this next slide, you see a spectrum of community engagement. And it's important to note that not all of the research just automatically begins at the far right end there. But it should start somewhere on this spectrum, I believe, and always should be pushing towards the pursuit of equity and engagement. So our role as investigators is to try to continually push our research forward to the extent that we can empower patients and our community stakeholders to facilitate the creation of plans and organize research functions in a manner that's going to be most meaningful and always oriented towards positive change for patients and their communities. And that brings me to the very last slide. And that what we're trying to do now is to continually push ourselves down that spectrum so that we can further engage in more meaningful ways and address the needs of even more populations in the best ways that we can. And with that, that's it.
Thanks so much, Dr. Irby. We got a little bit of a late start, and we'd like to respect everybody's time. We'd like to be able to have the other investigators speak and have time for questions and answers. I propose we take a 5-minute break. Come back at 3:30, and then we will hear from Dr. Johansson. Thank you very much, our participants and all the members of the webinar. So we're going to try to stay on track. We're going to ask our investigators to limit themselves to 8 minutes so we have some time for questions. Dr. Kirsten Johansson is professor of medicine at the University of Minnesota and is going to tell us about her work as an investigator in the HOPE study.
Thanks, Paul. I will try. I thought I had 10 minutes, so I will do my best. This is going to be a little different than the others, so that's good. It hopefully will be complementary. If you could go to the next slide. I put together some slides to explain to this group what HOPE is about and why we're doing it, because dialysis and that environment I thought wouldn't be familiar. And then I realized that the patient video really did a better job than I could ever do. So I want to start this presentation at the end by showing you our patient recruitment video that our patient advisors created with us. So this is about 5 minutes, and then I'll talk fast after that.
My name is Dawn Edwards.
My name is Dave White. My name is Carolyn Wilkie, and I have spent the last 10.5 years on hemodialysis.
I have been a kidney disease patient for 28 years.
I spent a total of 6 years on dialysis.
I have renal osteodystrophy, and I stepped off of the curb one day and I fractured my hip. And it was the worst pain that I ever experienced in my life.
For me, pain and kidney disease go hand in hand, unfortunately. I remember when I was first diagnosed with kidney failure, the doctors were asking me, where does it hurt? And the only answer I could think of was it hurts all over.
One of the times that I've had pain was when I got my third access placed, and it was a really big surgery and they had to make a pretty long incision. And ever since that incision, I've had nerve pain in that arm, and it's something that I just kind of have had to live with because there's not a whole lot they can do about it. It was really difficult for me to explain my pain to others because I'm not one that likes to share if I'm in pain or hurting. I like to brush it off and say, oh, I'm fine.
When I described my pain, I know that I was heard, but I'm not sure that I was understood.
When I would tell others, like my friends or family, they would just say, oh, everybody deals with pain. You'll just have to get used to it.
Sometimes I was a little more comfortable, and then other times I was just miserable. Unfortunately, I really didn't have a role in choosing the type of medications that I was prescribed.
I've tried a lot of different opioid medications, and all of them have given me side effects that I don't feel like is worth it for the pain relief.
There was just sort of a gap there in communication that I think could have helped my experience as a dialysis patient.
Looking back, one of the things that really could have been more helpful to my treatment is if we had tried some type of non-medical therapy to help me to deal with my pain without using medications at all. We are not alone in having pain. Over half of patients receiving dialysis treatment experience pain during any given week, and we are more sensitive to bad reactions to pain medications.
Studies show that hemodialysis patients who take opioid pain medications have a higher risk of falls, fractures, hospitalization, and death than those who don't. And pain itself is related to poor quality of life.
HOPE is a research study designed and geared specifically toward patients being treated with hemodialysis. And just so we're on the same page, HOPE stands for Hemodialysis Pain Reduction Effort. The main goal is to reduce how pain interferes with the lives of people who receive dialysis treatment.
The HOPE study is part of the National Institutes of Health HEAL Initiative to find scientific solutions to stem the national opioid health crisis.
The study is funded by the National Institute of Diabetes and Digestive and Kidney Diseases, which is also known as NIDDK.
The HOPE study is testing 2 ways to improve pain management. The first method is called pain coping skills training and involves one-on-one sessions with a trained coach to learn skills to help you manage your pain.
The second method is a medication called buprenorphine, and it may treat your pain with fewer side effects than traditional opioid medications. You do not need to be on pain medication in order to participate in this study, and you will not be required to change your pain medication if you decide you want to enroll.
Most study visits will occur by telehealth or video chat with the study team. This means that you can arrange those visits to best fit your schedule.
Participation will last between 8 and 10 months, and you will receive compensation for contributing your time and effort to the study.
By participating in the HOPE study, you could help your fellow dialysis patients.
The knowledge gained by your participation in the HOPE study could help patients with their pain.
If you have been suffering from pain that has gone on for 3 months or more and you think this study might be a good fit for you, please go to www.hopehdtrial.org or contact the person who showed you this video to get more information.
Great. Okay, thanks. If you could go to the next slide. So that was, isn't that great? That's what our patient advisors put together. As you can see, they had major input into that. Anyway, so that's sort of the end result in some ways, but also not the end. So why don't I tell you a little bit more about what's going on with the patients in the HOPE study. So, you know, one thing about this study that, as others of you have talked about, is patient engagement really was baked in from the beginning. And that's unusual, you know, coming from my background, which is sort of biomedical research trials. That's not the usual way, but we were encouraged, required, you might say, to engage patients right from the beginning from the RFA. And then because it was a UO1 funding mechanism, all the study centers came together to really finalize the design, and the patients were involved, as Dawn mentioned, sitting at the table for that right from the beginning. So I was going to tell you about hennepin patient engagement in particular. I'm conscious of the time, but maybe go ahead and go to the next slide. Yeah, so this is just to say that I had actually just moved to hennepin and my patients were Spanish speaking. So I had a little thought of who am I going to engage in this, but we had published this study. And if you want to just go to the next, actually one of our premier research journals actually found one of our patient advisors for me because they engaged David White, whom you saw in that film, to write an editorial and give a patient perspective about opioids in patients with kidney disease. And he said that we needed a holistic strategy for treating pain and that it should be developed with the goal of balancing pain with patient care and with taking into account patient and partner values and preferences. And so I thought, oh, he sounds like he might be interested in helping out. And if you want to go to the next slide, this is just a picture of him that I put here, but you already saw him on the video. He graciously agreed to join and has been super active in this study. And just next slide. And then this is our local patient representative from the Hennepin, Joel Williams, who's quite a character, as you might guess from this picture, and has also been extremely helpful. Next slide. So I just wanted to, the purpose of this slide is mainly just to make sure I remember to tell you, and that you can look and see here, that patients have just been involved at every single level, that in the steering committee meetings, engaged actively in the design, in the consent form, which I'm going to talk to you a little bit more about, and then moving forward, developing these recruitment materials, you saw the video, and moving forward from there, they're involved in monitoring recruitment and retention, and also monitoring the intervention itself and its delivery. Next slide, if you could. So I wanted to walk you through a little bit how the patients actually shaped our recruitment materials besides the video. It was the patient's idea in the first place that we ought to have a one-page flyer. So this is the first prototype, and this was just me. I put this together, so I don't know anything, but it was just to give people something to look at. What I need you to do is just go one by one through next slide, but it'll just pop something up there if you could. Great, and next. So I just wanted to point out, first of all, what Dave said in the video isn't actually true. HOPE doesn't actually stand or didn't stand for the hemodialysis pain reduction effort. It actually stood for hemodialysis opioid prescription effort. But the patient said, "You sound like your drug dealers trying to give us opioids. That's not a good name." So we redesigned what HOPE actually stands for, and now it stands for hemodialysis pain reduction effort, and that came from the patients. Page down 2 more, if you would. I just wanted to point out that this logo, the patients were really actively designed in this, just making sure that this little thing here looked to them like a dialyzer. You guys probably don't know what it is, but it's actually a dialyzer cartridge. And then this tagline, helping people on dialysis manage pain. That was a lot of back and forth. In our world, we're told we shouldn't say patients on dialysis, we should say something else. And they said, what are you talking about? That's who we are. So that was them as well. And just page down 2 more. So they liked these little these are joints that are sort of looking like they're aching, and they liked that implied that pain could be anywhere, it could strike anyone. They liked that concept. And 2 more, and I think we're done. Yeah, and they liked this image of beating pain or getting control over it was something that they really liked. So next slide.
Who's got to sum up now?
Oh boy, okay. So then the coordinating center got involved and put together this prototype, and the patients loved it and hated it. They loved the idea that it got at, again, pain striking anyone, but these faceless people were sort of freaky, so they provided their input. And if you go to the next slide, this is where we ended up with a really nice looking flyer that really does represent the spectrum of people on dialysis. And if you could just go to the next. And page down. So I won't read this because I'm out of time, but I did want to just say that Dawn mentioned this too, that the patients were actively involved in consent form language and actually told us some very specific things that they did and didn't want to have in the consent form. And those things were adopted, and the IRBs didn't have any problem with it, even though we removed some standard language. So I'll stop there and thank you for your time.
Thank you for being mindful of the time. And our next speaker is Dr. Richard Schottenfeld, who's a professor of psychiatry at Howard University.
Great. Thank you very much, Paul. And thanks for inviting me to this fabulous panel and symposium and workshop. So I'm going to talk about the work we've been doing in Washington, D.C. to answer Paul's initial questions. I'm a psychiatrist. I treat patients with substance use disorders. I develop clinical treatment programs. I try to make them more accessible. I teach people about substance use disorders, try to figure out how to make treatments more effective. And often treatments more effective means getting effective treatments to be used more. And that's really the question I think Dr. Baker mentioned at the beginning. What you see here is the logo, the Better Together, and the logo that our Community Advisory Board pulled together. I should say I moved to Washington, D.C. about 3.5 years ago, and this was my introductory project. It's also really the first time that I've made such active use of a Community Advisory Board. And for the purposes of today's panel, this has been a great big project, and working with the Community Advisory Board, it's been a spectacular both learning experience and human experience for me. So this graphic is a graphic of the map of Washington, D.C. And the lower 2 dark blue panels and then the red panels just above it are wards 7 and 8 and 5 and 6. And those are the areas that have experienced the highest rates of opiate overdose and fastest increases in the nation nationally. There are also predominantly African-American populations living there. And almost all the people who are dying and almost all the people with opiate use disorder are not getting treatment. But we know that treatments could prevent overdose deaths. So the big question that we're trying to figure out is how can we get this effective treatment to be better utilized and what gets in the way of we started off, can I get the next slide? Zip through them. This is our partnership. It includes our community advisory boards, other people. Next slide. I've given you the background, so I'll go to the next slide. I'm going to get this thing done in 8 minutes. So here's our community advisory board. Like others, every step along the way, we've been guided by this board, and the members are listed here. And I think Ms. Walker and Kevin Charles have already talked about the disparate group of people. I want to just say that the trust issues that people talk about go in all ways. So their trust for an investigator to develop trust with a community advisory board, for me to be able to trust them, for them to be able to trust me, and ultimately for patients and families and communities to be able to trust the board and us if we're going to get engaged in treatment. Next slide. The board spent a lot of time thinking through really what's the mission. They understood my research mission and came up with a powerful, the mission of the Washington, D.C. Reach, Engage, Retain project. It's for wards 7 and 8 to be healthy, thriving community where residents experience freedom from problems with substance use and addiction. Our mission is to increase access to effective recovery and treatment services, reduce stigma, and deal with the root causes of unhealthy drug use. Next slide. That vision statement and mission statement reflects a lot of discussion and importance shaping the project. And one, don't go in thinking this deficit models. Communities have strong, deep roots and strengths. Let's build on the strengths and strengthen the community. Second, there's deep suspicion about this sudden focus and sudden influx of money to focus on opioids and in communities that have been hard hit with substance problems for very long periods of time that haven't seen this type of resources. So why now? And why this sudden focus? And is it racist, racially motivated? White people are the face of opiate addiction and now money's coming in. And you can't just focus on opiates as the problem. There are other substances, there are other drugs, they're even more important. And even though the money comes from opiates money, it has to be broader than that. And don't focus only on drugs. Drugs are just a symptom, part of a larger set of problems. We need to be able to take all of them into consideration. Next slide. So the project, and I won't go through it in detail, but we set out now to get an understanding of what are the barriers and facilitators to treatment, to its use and its effectiveness, and what types of strategies and settings may be effective for engaging and retaining people in effective treatment, people with opiate use disorder and effective treatment. Next slide. Our very first step had some students involved and created an asset map. What are all the organizations, churches, community centers, recreation centers? What's in the communities that we can build on, and who are the community leaders? Next slide. And then we conducted lots of interviews. Next slide. And we heard from the interviews, there's a lot of interest in improving services. There are many community trusted organizations that can provide some of the services. Let's build on them. Next slide. There's also enormous misunderstanding about treatment, and there's bias against medications to treat opiate use disorder. And you can see the quotes. Methadone is legally maintaining a person. Suboxone, you're supposed to wean somebody off. Why should somebody be on it? Next slide. There's a huge amount of stigma that we're aware of. I don't want outsiders getting fixed in my community. They're the other. I'm worried about them. They scare me. Next slide. We heard from patients and people with lived experience. Treatments really work. I can be a good advocate. Next slide. And there are community resources that people trust that could serve as sites and opportunities to intervene. The churches, pastors, community leaders, all can be engaged and are interested in being engaged in productive solutions. Next slide. We're going to need models of success. We're going to need to link it to other activities. We're really going to need to have an effective anti-stigma campaign, engaging trusted leaders, trusted people, and patients in recovery, peers in recovery. Next slide. So I think Ms. Walker talked a little bit about it. as we're moving into the advisory board, shape the focus groups and are shaping the interventions that we're now moving to pilot and test, which is to train community leaders, churches, community centers in screening and brief intervention and getting people into treatment, to develop some locally based treatments inside those institutions. They come where we may sort of work on hub and spoke models and provide the treatment to them in their settings. And next slide. We just go to the end. So I'm done, maybe even ahead of time. Last slide. So that's our Better Together initiative. You know, for me, the project moves slower at the beginning, but it's been steadier, and I've learned every step along the way. And I think you've already heard earlier today from a couple of our community advisory board members. So you can see what a really powerful partnership we've developed. Thank you.
Thanks, Dr. Schottenfeld, for an inspiring talk and for keeping us on time. Next, we'll hear from Dr. Linda Sprague Martinez, who is an associate professor at the Boston University School of Social Work.
Hi, thanks for having me today. Good afternoon. And thank you for letting me talk about the Healing Community Study Massachusetts. You can go to the next slide. I'm going to give you a quick overview of the study, which was mentioned earlier, so I won't go into full detail. I'll talk specifically about some of the community engagement that we are doing, what's working, ongoing tensions and challenges, which we heard about from the first panel, which was wonderful. And then I'll talk about some of the benefits of partnership and show you some examples of what community engagement has led to. So you can go to the next slide. This is a slide, it's a little bit busy, but it's an overview of our study. And I really appreciated Chris Beasley made this point in her presentation about maybe we need to start at the end and then move forward. And for us, we know that there are evidence-based practices that work, but how can we get them to be translated in communities? And so Healing Community Study uses a Communities That Heal intervention to work with local community coalitions through a phased planning process to adopt evidence-based practices from a menu of practices to reduce opioid overdose. And so you can click to the next slide. It's a little simplistic way to look at it is that it's based on the Communities That Care model, and that you're bringing a community coalition together to get started, get organized, develop a charter, make sure everyone's at the table, look at local data, and then to create an action plan from a menu, implement that action plan, and think about sustainability. At the center of our intervention, there's a communications campaign to reduce stigma as well. So you can click to the next slide. And this is just that we're 67 communities across 4 states, Massachusetts, Ohio, Kentucky, and New York. Next slide. And I think what's special about this study is that it's really built on the premise that communities know what they need, and we as researchers need to be working in partnership with communities if we're going to translate best practices at the end of the day. So you can click to the next slide. This is a definition of community engagement that we use to guide the overall study. It's from the CDC. It's been around for a little while, but in short, that we're working collaboratively with folks, and that can take a lot of different forms. Community engagement can look a lot of different ways, and I'll show you some of the ways in which we're engaging. We're using community engagement. You can go to the next slide. So within community engagement in Massachusetts specifically, what does that look like? And this looks, and across states, we have this similar piece to our model, and that we have community teams that are working with our within local communities, and they're really the catalyst of this work that's happening within coalitions. And so we're using external facilitation, where a community engaged facilitator will work with a coalition that's led by a community coordinator. There are also community community faculty who have expertise in addiction science, and then community data managers to work with local coalitions around thinking about how they want to look at data that we are providing, what data is available locally that we can benefit from. You know, a lot of times we think as researchers that we bring the data, and that's not true. We do bring the data, but communities are also collecting data. And so how can we kind of get a broad understanding? We have community partner organizations, and then we have a community advisory board, or a CAB. So you can click to the next slide. In terms of, this is Massachusetts, map of Massachusetts. We have 16 communities. They're all diverse. We have rural communities, urban communities. We have municipalities that service communities, and then we have clusters of small towns. And so you can go to the next slide. And the thing that diversity brings up, it's just a reminder that communities are complex adaptive systems, right? That they're constantly evolving and changing, and that within communities, every organization that we work with has its own culture, its own norms, a way that it operates. And all of those, a main goal of any system is to maintain equilibrium or balance. And so just by nature of us working with communities, we have to keep in mind that balance as we're working with communities. We may feel pushback, that's normal. We may be welcomed in, the system may loosen, but we really need to just keep in mind how power is operating within those systems. You know, there are many sectors of community life that are at the table, so we kind of really begin to get a sense of the community broadly before we're entering. I really appreciated Dr. Schottenfeld's asset mapping. That's something, we had a landscape analysis at the beginning, really understanding what's there, what's working. You can click to the next slide. We also had to think about training. You know, not all of us we have a very diverse team. It's a, you know, transdisciplinary team of researchers that are health economists. There are social work researchers, there are addiction scientists, there are implementation scientists. I mean, I could go on. And we all speak a different language, and not all of us do community engaged research. So we really spent some time in the beginning doing some level setting. We started with, you know, a quick community engagement 101 to move to a half-day workshop, so we can begin to have a shared language. We use the principles of CBPR, although we are not a CBPR, community-based participatory research study, but we do have those same values, and that we recognize that there's expertise in our local communities and we want to learn together. So click to the next slide. This is a picture of our community advisory board at our first and last full board in-person meeting. The board is made up of people from across sectors of community life. We have folks from healthcare, behavioral health, local governance. We have people from justice. We have people who use drugs. We have people who've been incarcerated. We have people, I think most people on our board have lost a friend or a family member to opioid overdose. And the other thing, we started with 7 core members, and the 7 core members, they were part of the grant writing team. They really said when they came together, we're not a very diverse group. We need to think about, when we recruit this whole board, how we can do a better job. And they held the study accountable to doing that. They came up with our recruitment strategy in partnership with us, and it was very exciting to see the applications we got. They voted all the members in as a board, and they have their own process for bringing in new members if there is a transition. You can click to the next slide. The main goal of the CAB is they're an advisory body. There is a member of the CAB that is a liaison to every core of the study. We have multiple cores. And I put this picture up in the corner, in that the CAB recently held last month they held a harm reduction training, and it was led by a CAB member in partnership with a member of the research team. And they had this initial first question on the board: what does harm reduction mean to you? And then they used the annotate function that you can use to write on the board to say what harm reduction meant to them. And it was a very powerful activity. So you can click to the next slide. We also use partnerships. We have partner organizations as a form of community engagement. Those are our local OBAT sites. We have fiscal agents that hire community coordinators. When the coalition allocates funding to an intervention or evidence-based practice, they would handle some of that transferring of funds there. And then we have the many implementation sites across the study where evidence-based practices are being implemented that are partner organizations. You can click to the next slide. And then the coalitions themselves are really the heart of the work that we're doing. The coalitions are governed by a charter that they create. They determine their own structure, their decision-making structure, procedures for membership. That's all determined by the coalitions. They all look different in the community, each of the 8 communities. They're facilitated by the coordinator. I mentioned the data manager, but the key thing is that they're selecting the planned interventions and working on the implementation plans, and they're allocating the funding, and they're doing the monitoring of the interventions. That all happens in the context of a coalition meeting. You can click to the next slide. In terms of how the coalitions were built, some communities had existing coalitions through external facilitation. They thought about the membership, who needs to be at the table, who's not here, who are we missing, whose voices aren't we hearing. They work with municipal leadership or public health officials, and then sometimes they started where there wasn't a coalition. They had to bring folks together. But then there's constant widening of the circle, conducting one-on-ones, listening sessions, thinking about who's most impacted. Do we have them here? Are we hearing their voices? We have amazing community teams that have really just catalyzed great work and coalitions. So you can click to the next slide.
Dr. Martinez,
Yep.
I hope you'll be able to summarize.
Yep, I'm going to go quickly to what's works. You've heard a lot about this. Be intentional about hiring. We've done some hiring equity. Understand local dynamics. Hear people. Listen to people. Be transparent. For us, we had to be uncomfortable with uncertainty and sitting with discomfort, right? I mean, we had to be comfortable with uncertainty and sitting with discomfort because community processes, we don't always hear what we want to hear. Click to the next slide. And then also this challenges we heard. I feel like I'm shouting into the wind, we heard from one member, and that, listening is not enough. We need to listen and we need to value the voices of our community partners. And then I just want to make this point about trust. We talk about mistrust. I heard a researcher speak the other day about we need to be trustworthy as researchers. And I think that's a really important point. What does it mean for us to be trustworthy? You can click to the next slide. Click to the next slide. Communities know what they need. I just wanted to share with you that some of the positives in terms of the benefits, I just have 2 slides I'll share, that, a coalition in Holyoke, they identified a treatment desert. Now they have groups working together to put together an opioid treatment program in that community where providers are working across sectors to really stand up an intervention and integrating with a local health center. And then another positive, and there are so many that I could share, but I'll just share this next one as well. You can go to the next slide. In Brockton, we have the Neighborhood Health Center working with a area multi-service center, and they're working on a clinic on wheels to really, transportation is a huge barrier to treatment, and so thinking about how we get treatment to people, you can see a picture of it on the next slide. And so that's what that will look like. But I'll stop there. Okay. These are our communications campaigns that were also tailored by coalitions. So that's it.
Thank you very much, Dr. Martinez. You spoke quickly so that a Brooklynite could appreciate your patter. So
I'm from the other New Hampshire, but we speak fast too.
Helping us keep on time. We'll hear from Dr. Camilla Venner, who's an assistant professor of psychology at the University of New Mexico, and she'll tell us about her work in Native communities.
Yes, thank you so much, Paul. And I just want to give a quick thank you to the organizers and the folks that were helping us, like Kim Williamson and Greg Richards and Petra Jacobs, and even Carmen Rosa, who helped connect me. And to all the speakers, the earlier speakers, of the people with lived experiences, and then also our researchers, because that's what it takes, is the whole community of us. So I just wanted to talk about improving our science, partnering with collaborative boards in American Indian and Alaska Native communities. So you can go to the next slide. So my overview is that I'm going to, instead of talking about one study, kind of glance off a few examples. So hopefully you'll get a feel for how I have learned from working with people with lived experiences or community board advisors. It reminds me of just language. I'm just so interested in the language that everyone uses. And I loved citizen scientists. I thought that was beautiful. And today we're talking a lot about patients, which is more medical model. Clients might be a little different. In our studies, we've been using consumer lately. I've heard consumer owner. And in some of our American Indian Alaska Native partnerships and tribal programs, they use the term relative, and they'll find out their relative connection through a clan relationship, and they'll use that. So language is important. So the first study I'll talk about is what I learned from leading a NIDA and a AAA special meeting. And so we'll talk about a mismatch between Western and traditional models. The second one is partnering with a tribal council for a different project, and I'll focus on assessment and spirituality and what I learned there. The third one is partnering with collaborative boards and what I learned there, and including mind maps, which demonstrate this sort of whether we center Western models or we center cultural models, and then we'll conclude. And that figure there is from the NIH initiative, HEAL Initiative, and it sort of shows how American Indian, Alaska Native conceptions are holistic and everything's all together. So you don't just compartmentalize one piece and look at it, you look at everything all together: physical, biological, psychological, social, and spiritual. Next slide. So the first one from the meeting that I was able to lead for NIDA, to bring together different perspectives, American Indian, Alaska Native perspectives on medication treatment for opioid use disorder. So we had a lot of different people. We had traditional healers, we had American Indian, Alaska Native treatment providers, program directors, we had some prescribers, we had non-Native allies, anyway, so we were trying to get a lot of different viewpoints. And the first theme that came up is that there's often a mismatch between our Western treatment models and American Indian, Alaska Native healing models. So in that little table right there, on the left-hand side, we have the EBTs, or evidence-based treatments that come from our science, the academic science, Western science, and then traditional healing on the right. And some of the ways that they mismatch is that evidence-based treatments are often conducted in dyads, so 2 people in a room, maybe a family, whereas traditional healing can include the whole community. Whereas unfortunately, our specialty addiction care treatment programs often are stigmatized. Traditional healing ceremonies are admired when you participate. Evidence-based treatments are all secular, except for the 12-step model, or 12-step facilitation, which didn't come out of academics, that came out of people who had recovered. And traditional healing is sacred. And then, of course, in our evidence-based treatments, we don't have explicit guidance for culture. And in traditional healing, it's all about preserving culture. The second piece that we learned from the second theme, I guess, is that we need to integrate medications for opioid use disorders into American Indian, Alaska Native treatment, traditional healing models. So one of my favorite quotes was a traditional healer who's also a substance use counselor said, when he talks to his patients about medication treatment, he tells them, we had the MAT before the MAT. So we have always been using plants and herbs medicinally, right? And so he just used that framework to then introduce these more synthetic medications as treatment. So then the third one was a conflict between standardized MOUD delivery and a desire for healing to result in people being medication free. So this ended up being a little bit of a heated conversation because our Western tendency is then to argue, well, what about other chronic conditions? What about diabetes? You might need to stay on medication for that, which ended up making it seem like the traditional, viewpoints and values were not as valued. But we got through it, so that was good. That's another piece about working across, I think, divides, is being willing to have conflict and resolve it. But they did talk about wanting to be whole. So I guess having people with lived experience from the community really helps us check our Western models and to expand them and I think make them better. So let's go to the next slide. So I just want to focus quickly on assessment, which is really based in Western culture. So a lot of it's developed by people who are non-Hispanic white and tested on people who are non-Hispanic white. And of course that's changing, but too slowly, I think. So next slide. So with one of my tribal partners, this is the NIDA funded R01, we knew spirituality would be important. So we looked in the literature, we found a measure, which was the daily experiences of spirituality. I thought, this is great. I brought it to my tribal partners and they rejected it. Nope, we don't talk that way. So we asked them how they did talk and what would work. And so here's 4 examples. But the last one I'll point out, the original says, I'm spiritually touched by the beauty of creation. So I thought, oh, that's perfect. Land-based, you know, no. But they said, I'm spiritually touched by participating in my faith. And so we ran the psychometrics and looked at the changes in spirituality over time as well. So that's also turning our focus away from reducing pathology, but to increasing well-being. And that was published by my past student, Brenna Greenfield. So had I not checked in with the community, I would have been using a measure that didn't make sense to them. And then I wouldn't have known what to make of it. Okay, next slide. This is my team for a NIDA Clinical Trials Network study, which we refer to as numbers. So this is clinical CTN 0096. And we have hardworking, smart people with a lot of heart. So you want a team that values, you know, the community and community voices. Next slide. And similarly, here's our collaborative board first and only in-person meeting, October of 2019, here in Albuquerque. And I learned a lot from them, but I don't think I can share it all with you today since we're running out of time. And by the way, thank you for sticking with us. So the first one is the relationship and the authenticity. So having these relationships is not just to use people for their information, but to really get to know them as people and to learn from them and to care about them outside of the research as well. So we have a lot of laughter. We enjoy eating together, or enjoyed when we could. The second point is one of the people with lived experience told her story about going to treatment. Actually, before she even went to treatment, she was in a hospital and 2 of the counselors met her in the hospital to start developing that relationship. And she said, they loved me until I could love myself. And we don't often talk about love in our evidence-based treatments, but she was talking about feeling accepted and people thinking she's worthy before she could believe she's worthy. So bringing those stances to the programs and to the providers, I think, is super important. Let me see. There's so many more things I could go on here. We have a traditional practices work group, and so we're learning about some programs giving medicine bags at the beginning to welcome people, using Native American coins to celebrate milestones, and ceremonies like a blanket wrapping ceremony as they complete that program. So we'll be offering things to our sites that we hope to work with. The measurement work group is amazing. So we're trying to bridge programs in Alaska versus programs in the contiguous 48 states. And so there's reservations down here, there's not in Alaska. So just trying to think of all the different ways that we can be more inclusive and take into account heterogeneity. Well, let me see here. I think we better move on to the next slide.
I'm going to have to ask you to sum up in perhaps a couple of slides.
Sounds good. So this one's just to show you that in that collaborative board, we asked for feedback on 8 questions, and here's one. How can American Indian Alaska Native people incorporate medications into a holistic approach to wellness? Well, the first group came up with a flip chart on the left that had medication-assisted treatment in the center and tried to move out from there. Another group came around and said, no, 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 we're putting holistic wellness in the center and we'll move out from there, and which is exactly what we're trying to do. So the next slide. This is another team that I'm working with from NIDA funded studies, and you can move on to the next slide. So in this one, we're trying to improve accuracy of American Indian Alaska Native data in New Mexico. And there's lots of reasons it is inaccurate, from misclassification to other things. And so we present information to the collaborative board to give them research information, to have that direction of learning, and then we ask for feedback back. In the first presentation, they were like, well, what about focusing on strengths? Which I was like, that is my whole world is strengths, and I forgot to remind the person that was doing that part to focus on strengths. And the second part is we're presenting some of the findings from our research and getting feedback. And this one was on how might social support impact opioid use, and actually some other negative mental health outcomes I can't share just yet. And they said, well, duh, we know social support's important, so give us something else. So they were frustrated. But then they said, you know, as we talked, that they know not everybody in the tribe gets the social support they need. So that might be a message. And we looked at the questions and they said those questions don't capture all the different kinds of social support people can access on the reservation. So they invite us to expand and include things in our discussion. So the next slide, which I think is my conclusion slide. Yes. Okay, so in conclusion, our Western training doesn't always prepare us to work appropriately with communities that we hope to impact positively. And the Western training is so ubiquitous that even I get sucked back into it and have to be reminded along the way. Secondly, working with our community members and those with lived experience helps us check our assumptions and our models. So we don't often include spirituality, for instance, whereas in the US, the vast majority, over 80% of the people in the US will say they believe in God or a higher power, and we don't have explicit ways to incorporate that in most of our treatments. Third, they improve our science from, as you heard today, helping with design issues, making them simpler or more complex, who knows, measurement issues, highlighting strengths, and then finding ways to culturally center our treatments. It's very rewarding work. We care about each other, we learn a lot from each other. And so I end with, why wouldn't researchers want to work with community members, such as those with lived experiences with substance use disorder and healing? Thank you very much.
Dr. Venner, thank you so much for focusing us on important cultural perspectives. I hope the audience on this webinar will give a virtual hand or perhaps a shout out when you take yourselves off mute to our 7 participants who worked under terrible, terrible time constraints. I thank you, and I think the whole HEAL program and all our listeners thank you. So I'm waiting for all those clapping hands to appear on the screen. I'd like to be mindful of the fact that there were questions that were raised during the discussion, and there were some questions that were raised beforehand. We have 7 eminent panelists, so trying to split with the people who asked questions before we started the webinar and those who participated in the webinar. I'd like to bring up for your consideration panelists. Nan Kennedy asked, how do you express thanks to participants? And I'd like to add to her question, and advisors in your studies. So how do you say thank you to the patients who are working as advisors and the people who are participating in the studies? And if we have time, we'll go back to a question of how each of you in your studies have worked to build trust with not only the patient advisors, but with the participants in your study, how you've kept the patients, advisors, and perhaps the participants as equal partners in research throughout the arc of research. So will you consider Nan Kennedy's question of how do you show thanks to participants and advisors? Don't make me call on you. It could be very embarrassing.
Well, I'll just say I don't really think we probably do enough.
Right.
That's my first thing. But what I will say though is that I hope that the way we, even if we don't say thank you directly, I hope that the way that we express it is by listening and by respecting what we hear and by adapting our work as a result.
Thanks. Other perspectives?
I like to say, first off, when we're dealing with, this particular type of people, they're overcoming barriers, so they basically getting their life together. So what we want to most definitely be sure to do is keep these people in the loop. You know, when we have things going on, when we have little small groups, when we want to get together and talk about positive things in our lives and things of that nature, keep these people in the loop so that they can see us and so that can help them overcome these barriers and help them stay inspired and motivated to overcome more barriers. Another thing I want to say is even like I know sometimes like I know for my part-time job, you know, we give out meals and things of that nature out in the community. So even for a person that might, you know, come and just, you know, want, you know, a physical or just need, you know, a substance abuse counselor, offer those people, you know, meals, you know, offer those people, you know, any type of incentive that, you know, they feel like may help them along the road with getting there or even getting back home. I feel like that's very important that we keep them people inspired by doing positive things with them so that when they're not around us, that they will be able to do positive things for themselves.
Thanks, Mr. Charles. Any of our investigators have ways that we've shown appreciation for the participants in studies or our patient advisors? I know that in HOPE, our patient advisors are compensated for their time and participation. Do you want to comment on that, Kirsten?
Sure. Yes, they definitely are. But I don't think that's why they do it. I think it's important though. I think it's important to show that it's valuable in the ways we usually traditionally do that, and to compensate them. But it took us a while to get that mechanism even going, and they weren't complaining. They were waiting patiently, and I don't think that's their motivation primarily.
But just like
I wanted to make a comment on the compensation part, and thanks. You know, I think compensation is critical for people who spend time, and often time that pulls them away from work. Or that you know, many of the people on our advisors and board would otherwise lose pay, and they can't afford that. And nobody should have to do that. I get paid to show up. That's where my salary comes from, and I think that community advisory board members, that's part of the respect and awareness. So I think it's important to do. I don't think that's why they do it. You know, I completely agree with, you know, Dr. Johansson, but I think it allows it. Things that we do for thanks, when pre-COVID, we had meals together.
Yeah.
You know, if we met in the evenings, we'd meet around dinner, and it was both, you know, it wasn't really to say thank you, but it was to share a meal and to get to know each other and to enjoy that type of interaction and, you know, really get to know each other. And so whether that's thanks or just connection, I'm not quite sure.
So I think the key concepts were respect and, you know, equal treatment. The investigators are paid to come to the meeting, and, you know, they have time and lodging. And we tried to do the same thing for our advisors. And because the advisors participate in the steering committee meetings over a year, we made sure that they could get consultation fees. And we're also trying to work on showing our appreciation and respect for the patients who are participating in the HOPE study. Any other comments about how we're doing this? How does that work with populations in New Mexico, Dr. Venner?
I think very much the same way. Yes, we compensate them. We had meals together. We had even some dancers and I think some music performers. So we had just a wonderful time when we were together. But I think it's also just the caring. So there's been a lot of trauma. There's been a lot of loss due to COVID. So we check in about those kinds of things before our meetings. Often the civil unrest, we check in. So I think it's about caring about them as people beyond your research as well. And then being in it for the long haul. So, you know, thinking of the next studies and how we can continue working together and what would be the next questions we might ask.
I'd like to add, oh, sorry. The value of cards and birthday cards, holiday cards, acknowledging special, wonderful things that happened with our team members, citizen scientists, patient brigade during this time. Like weddings or birth of a child. And then also, quite honestly, the very sad things that happened because we lost literally a third of our community with COVID. In some way, they're, if not themselves, but a relation. And so, you know, having them be part of the team, but also, you know, people that we deeply care about, them to know their birthdays and know the big things that are happening in their lives and how we can support them. Maybe take, you know, using the bus or the CTA wasn't really possible so much during COVID because it wasn't quite as safe. So, you know, providing Uber credits, those sorts of things. I think it proved to be really valuable and important during this time, in addition to everything, all the wonderful things that have already been mentioned.
You know, when I started out in research, my mentor, who was a psychiatrist, told me and the team that we should treat the participants in our studies as collaborators. And that sort of set the stage for how we were going to do research. Can the investigators comment on how you build trust specifically in your studies with the participants and the community and patient advisors as well? Dr. Irby, you had a very nice schema of how you iteratively learned during studies. How did you build trust in the network that you oversaw through Wake Forest?
We do a lot of self-disclosure. I think it's very important that when we're asking patients to give so much to us in terms of, you know, filling out all these forms and surveys and things like that, we should also be open and transparent about who we are as well. So putting ourselves out there as researchers is really important. I typically go right in and say, you know, I recognize that I'm this cisgender, educated, middle-class white lady, and I'm not going to understand your life's experiences. And my life is not generalizable to everybody else, but I need to hear from you and learn from your perspectives to help me do a better job of being an ally. So, and then from that point on, it's a lot more listening and putting myself kind of in the background to hear everybody else. And when I feel like the more they feel like their voices are the ones that have the power in the room, then there is, you can build more trust starting out on that foot. I also do a lot of recognition of historical atrocities and calling it out. You know, Wake Forest was complicit in the eugenics program for many, many years. And that's still in the living memories of many folks here in my community. So I call it out. We talk about what has been done, what hasn't been done, what issues are still lingering that we have not fully addressed. And I like to hear their perspectives on that too. So I guess in short, putting yourself out there and really, you know, disclosing these things that are uncomfortable to talk about is the first step, I think, in repairing some of those trust issues.
So you emphasized transparency as a key pillar of trust. Dr. Martinez, you showed us a slide that said transparency isn't enough.
So transparency, well, it's transparent, trust, transparency, and really taking the time, right? So I think a lot of times we talk about about what community engagement is, but our actions don't always match. And so it's really kind of living it as well. And so in taking the time to establish relationships with our community partners, trusting the process that the answer is in the group and that the folks that we're working with know what they need. And then I think that I agree that sharing of self, and that I think in transparency in that what can we do and what can't we do? We all have our limitations, and not not trying to sugarcoat things and not trying to say, not share information that we know people don't want to hear because we know they don't want to hear it, but having a conversation about it and really hearing from our partners what their needs are as well, and not always, and I think a lot of times we have our own deadlines as researchers that we need to meet, but we can't just prioritize our deadlines. We need to make our partners aware, like, we have these deadlines. I don't mean to pressure through. This is, if I'm pressuring through, this is what's happening. That level of transparency, I think, is important with our partners. But I really appreciated the comments about the cards and getting to know people. You know, if I think about our advisory board, Deb, my colleague who works with our advisory board, after every meeting, we call every person. She calls every person, talks to them, checks in. There are 22 people on our advisory board, but there's a level of trust that she has with the advisory board. And by way of her level of trust, that kind of people are more trusting of the rest of us as well. But we know when someone's dog has puppies, you know, we know what's happening with the board because we have a relationship. And so, yeah.
Well, thanks. Have investigators had problems convening community advisory board? I think you see how committed Hope is to the patient voice. However, we initially thought we would have 18 to 20 patients, and we really only have about 12 patients participating as a core group. How do you keep the patients and the advisors active in studies? I saw some boards that looked as big as 25, 30 people. I think that's great. Can you comment on, you know, keeping a large active board together?
I can comment. I think I've made the comment about, you know, reaching out to folks and talking to them. I think boards also need to know what the purpose is, why they're coming together. It's kind of like our CAB member made the comment, if I feel like I'm shouting to the wind, it's not going to be enough. I need to know, you know, what my role is, having clear roles. Our board co-developed a charter at the beginning, kind of spelled out their roles, what they were gonna contribute to on the board. It's a little different than most community advisory boards I've worked with on other studies that are decision-making boards. This board is an advisory board, not a decision-making board. So it's they make decisions, but it's just a different at a different space. So I think really having a clear sense and establishing relationships with everyone on that board, that's an important piece to getting folks and having a shared, because we all have that shared goal. We approach it differently through our work, but we have a shared goal that we want to reduce opioid overdose, and that's important to all of us. And finding that commonality around which we can all come together and coalesce is important.
Yes, I was struck by that comment, shouting into the wind, because in the 3 studies that I've been involved in, heavily involved in community and patient engagement, I've never heard that. So setting the groundwork is extremely important, I think. Other comments about some challenges with community boards, with keeping our advisors engaged?
I just want to add on to what Linda said. I think really doing the priming of the pump, as it were, for our citizen scientists to kind of give them the background information. This meeting is about the DSMB. This is what we're going to be doing. This is the sort of input we want. This meeting is about, you know, and queuing them ahead of time. And I love how you said phone calls, because yes, I guess when I brought up cards, I should have said, you know, avoid email, because I think that's been the death of maybe some groups. And I know we've had to turn to email perhaps a little more often now, because we haven't been able to get in person. But I think, yes, that coaching and the phone calls, I think, has been phenomenal.
Thank you. Can we turn to the issues of building trust? Dr. Brinkley Rubenstein, you talked about a very special population, you know, who are at a vulnerable moment in their lives after surgery. How do you build trust with patients when you're asking them to change their medication habits. Oh, perhaps Dr. Brinkley Rubenstein is not on the phone. Can any one of our investigators comment on how they've been building trust in difficult research situations after you've achieved recruitment? So focusing on retention.
This is retention of our collaborative board?
No, of the patients, building
patients,
trust, with the advice of your advisors. In hope, we've just started our study. We are 9 patients into 640. And we started our recruitment in December, so we don't have all that much experience with retention. Dr. Schottenfeld, can you comment on building trust in participants in DC at Howard?
Well, I won't so much from the study yet, but from this one, but from general treatment studies. And trust is part of the relationship that developing all along the way as you're trying to work with somebody and treating substance use problem. So there, it's all the issues that we've been facing. How do you demonstrate, show the respect for the person you're working with, your understanding, your listening? I think Kevin Charles earlier talked about listening, which is critical. People need to be heard, what's important to them, and have that valued. And I think there are areas where there's just so much trust that people are going to have in me as a white man who's not in recovery, and so that I need to be aware of that. We can talk about that. We try to have teams of people engaged in treatment. I often think the reason why we're successful when we hold people in is because there's somebody on the team that the patient has engaged with, likes, feels respected. And that could be the person who greets them if they're coming in those pre-COVID days to an office, the person behind the desk who first greets them, or the research assistant. Those are the critical things I think we're all always working on. And it's pretty easy to lose it too. Can't let up.
Right, just like with recruitment goals, we can't lose our balance in trying to maintain trust. I want to thank the panelists so much for their presentations and their answers to questions, and I'll bring it back to Dr. Haney.
All right, thank you all for your wonderful presentations and this amazing discussion. We wanted to have Dr. Rebecca Baker really give some of the final closing remarks, and I'll turn it over to Dr. Baker.
Thank you, Dr. Haney. Thank you, Dr. Kimmel, and all of the working group members who helped organize this incredible meeting. I confess that my head is still spinning a little bit, which I think is a good thing, because it means that we've been hearing different perspectives and different kinds of input than we typically do in HEAL, and that is always a good thing for me. And I have to say, Dr. Venner, later on, could you please send me those statements that your board put together? Because when I have an office again, I'm going to want to put them on my wall. Everything, all of these elements of our experience contribute to how we as researchers carry out our work and how we engage with the participants and partners in our studies. And so I'm just very grateful for everything that you've all shared with us today. I'll reflect a little bit on the beginning of the meeting. I mean, interestingly, we organized this first, the folks with lived experience, the patients, the advisors, the caregivers, and then next the researchers who are working together with these stakeholders. And gosh, I felt like there was a lot of commonality in what I heard on both sides. So although I'll try to organize it, I also think that there were threads really interwoven from both sides, starting with the folks with lived experience, the patients, participants, and advisors in our studies. The thread that I heard and the theme that resonated for me most, top of mind, was really the humanity of the interaction that we have with our research participants, and how important it is to protect and sustain that humanity in the people that we serve. And there are lots of ways to do this, you know, the active listening, the trust building. One reminder, something that came to me as a reminder, is creating space or protecting time, because there's uncertainty in that interaction. And as you know, funders like NIH or investigators, we want to have some kind of control and certainty, but in order to build that trust, you have to step back and preserve a little bit of time and space for your participants and patients and caregivers to give you their authentic input and to allow you to hear it and incorporate it into your research. And so that was a theme that I heard, and I think is something that we'll have to find ways to incorporate in across HEAL. I also heard a lot about bidirectional communication and the importance of recognizing not just, oh, we'll carry out this study and we'll share our data with research participants, or we'll share our research findings with research participants, but to really continue that nexus of communication and information sharing, because there is wisdom in the communities and there is data collection and knowledge among our participants that we as at the NIH and in the research community need to hear. Moving into the second section of the meeting, I heard similar themes in that one, but almost more strongly that, you know, communities know what they need. People in our research studies often know what they would like to learn from the study and are kind of waiting for us as researchers to get there and hoping that we do. And that, I think, is a promise that we, will take very seriously in HEAL. So just being able to say a little bit about what we have planned at NIH. You know, when I opened up the meeting, I said that we were planning a HEAL Community Council. And so this would be a group of individuals involved in our research studies as participants or advisors who could reflect across HEAL and make sure that kind of the things we're saying we're going to do, we are indeed going to do, but also providing input on an ongoing basis and allowing them to grow in familiarity with our research as it moves forward, but also as we take on all of the different kinds of research questions that are involved in HEAL. Then another notable piece of information is that we have right now funding opportunities. So a lot of times I think at NIH we say, oh, you have to do this and you have to do that and you have to do this and you have to do that and attain this recruitment goal and send us this progress update and meet this list on our checklist of things that you need to do. And we don't want to make this another item on the checklist, right? We want this to be a really authentic partnership and an opportunity for a sustained and meaningful interaction. And so these funding opportunities seek to provide resources so that the investigator groups can do this. And I hope that you take a look at that. And if you are an investigator, that you reach out to your program official for more information about it. And then lastly, I think that what we've heard a lot today reflects what is going really well in HEAL. You know, you're on the cutting edge of engaging patients and participants in the research process. And what we'd like to do is collect these promising practices and then share them more widely with the HEAL community. So not just saying you should do this, but really putting together some help and resources so that it is easy, or some of the barriers to adoption can be addressed. So that's something else that we at NIH, together with the Patient Engagement Working Group and HEAL, will be taking on. And so I'm just very pleased to have heard all of the insights and thoughtful contributions today. Thank all of the panelists, all of the organizers. Thank Dr. Volkoff and Korschatz, who I know are listening in and will be partners with all of us as we move this forward into action. So thank you very much, and talk to you all again soon.
Yeah. So thank you everyone for joining the HEAL Harnessing the Power of Patients and Stakeholders in the Research Process workshop. We've really appreciated your time. Thank you again to all of our panelists. We will have a recording of the workshop as well as associated slides with whatever needs to be redacted from those slides for our investigators available on the site. Once again, thank you guys so much. And we'll also have a summary of the meeting available as well. So please enjoy the rest of your afternoon. Bye.